Ranveer, like Ranveer and Deepika.
No, ma'am, it's just all of you all love us so much that it's like, it's just natural that we keep
This
doing.
is support team, ma'am. We are going live in 3, 2, 1. We are live now.
Okay, thank you.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. I welcome you all to this Perfection Series Season 8 webinar on the topic Everything About Endometriosis. It's an honor to introduce the co-convener of this webinar, Dr. Monica Jindal Singh. She is consultant reproductive medicine, endoscopist, sonologist, Bhopal Fertility and Endoscopy Center, Bhopal. She is honorary secretary, MP chapter ISAR. She is vice president of Bhopal Obstetrics and Gynec Society and Bhopal Menopause Society. More importantly, she is co-convener of ISAR Perfect Series, as well as she is the founder and convener of Foxy Symbiosis webinar series. Over to you, madam.
Thank you, Dr. Vishal. Thank you for the kind introduction. And today we come to the 8th episode of ISAR Perfection series. And this is everything about endometriosis. And just before we start the webinar, I have got instructions from our mentors and the convener that we have to stick to only a 2-line introduction. So my coordinator, Dr. Manisha Jain, to please note that. So less time is to be spent on intros and more on interaction. So endometriosis, there is no need. We have got stalwarts in front of us. It is enigmatic endometriosis. So when we first started conceived the idea of this topic for ISAR Perfection, we were thinking, how are we going to go on 3 to 4 hours about it? But gradually when we read about the topic, there are so many things new in this topic and so many points to be discussed that I think we have to take a good look at the topic again. Just a small example, surgery, which we were doing for endometriomas and omas, as they are called now, is now gone totally into disrepute. You first, take every surgical intervention with a pinch of salt. Now, instead of looking for hormonal suppression for a patient of endometriosis, we are looking for something like stem cells. And our brilliant speaker, Dr. Sunita Tandalwadkar ma'am, probably will give us insight as to how stem cells can help us in endometriosis. So without wasting time, I would like to thank our ISAR office bearers, President Dr. Nandita Palshetkar. No need to introduce her. She is a stalwart in the field of gynecology because of whose innovative ideas and because of whose vision ISAR has grown, Foxy has grown, every organization has grown. We welcome Madam for her always benevolent presence and her blessings. I also invite and I'm deeply honored to welcome Dr. Sujata Kar, who is as Honorary Secretary General ISAR, and Madam is a brilliant star in the field of ART, obstetrics and gynecology in Odisha, eastern part of India, where she has brought out the first baby. She has been awarded so many awards by the Odisha government. She is a prolific academician, and her chief interest I've seen over the years is PCO. She's also interested in latest advances like proteomics and metabolomics of male infertility and stem cells. Welcome you, ma'am. And Madam is also our guest of honor today. Next, I would like to welcome Dr. Sunita Tandalwadkar, Senior Vice President ISAR, and also the Foxy President-elect, Madam has just gone through a grueling campaign in which she has established all over India that she is the leader for Foxy. 2025 she'll take over, and we look forward to a brilliant year of Foxy under her wings. One thing I would like to say is that she is an innovator, and she innovates and we follow and we admire. And she has done this to stem cells seen in India. Because of her, stem cells has become, something which is within reach and possible. I welcome you, ma'am. Madam is also the speaker of our first session. Next, it is my pride to invite our chief guest, Dr. Asha Rao ma'am, who is the chairperson, Foxy Endometriosis Committee, and a very renowned gynecologist in the city of Coimbatore, Director Rao Hospital. She is at present heading a very big committee of FOXY, endometriosis committee, and we will come to know how important this disease, this pathology, and this committee is in the next 3 hours. Madam has been very, very kind to us by giving us time for this webinar. And she is also a keen academician, editor of FOXY Focus, convener for FOXY GCPR guidelines on endometriosis, and has been awarded a gold medal from President of India, and also a gold medalist in MBBS career. Welcome you, ma'am. We would like to have a few words from you, Asha ma'am.
Thank you, Monica, for those kind words and for the invite. I'm much honored to be here at this prestigious ISAR series, Perfection series on endometriosis. And as all of us know, the disease, which is more than 200 years old, has been so much studied, analyzed, yet we have dilemmas in diagnosis and disputes in management, and atrocious delay of 7 to 10 years in reaching a proper diagnosis. So it's very important that we have more and more discussions. Over the last 4 years that I have been a chairperson, I've seen so many changes happening, and I have been very lucky to make a follow-up of all these updates. And I also thank Dr. Rishikesh Pai, the FOXY president, for giving me the opportunity of being the convener for the FOXY Good Clinical Practice rules on endometriosis, and also for being the editor for FOXY Focus on endometriosis 2023. I'm deeply indebted to Dr. Pai and Dr. Madhuri Patel for this opportunity, and also for being the co-editor and editor for many other books. And today I'm happy to share today's platform with the eminent galaxy here, Sujata Kar, Dr. Sunita Tendulkar, and then we have very many eminent chairpersons. And most of anything, I'm very happy to be here with the power couple, the Singh couple, like Ranveer and Deepika. We have here Ranveer and Monica. She's a vibrant, dynamic personality and the upcoming star, and I wish her all the best in her future endeavors. Today we have very, very nice topics, and I know all of you are waiting to listen to these topics. So let me not stand between the discussion and the delegates. So thank you, Monica, once again for having invited me here. Thank you.
Thank you so much, ma'am. Next, I would like to invite our guest of honor. I think Dr. Lakshmi, madam, has not joined till now. Has she, Purnima? No. So, Dr. Lakshmi, ma'am, Dr. Purnima, Dr. Manisha, could you please call Lakshmi, madam?
Yes, ma'am, I'm calling.
Okay, I invite our guest of honor for this evening, Dr. Sujata Kar. We have already introduced ma'am, and we just would like to have your blessings and a few words from you. And all the best for your forthcoming elections, ma'am.
Thank you, Monica. Thank you for inviting me. And it is this great Perfection series. You've given such a beautiful name. And today's program, I have gone through many of them, but today's program sounds also so perfect in endometriosis, where there is so much to cover. You've got in all the galaxy main speakers. You've got hold of Sunita. You've got hold of Damotar. You have Anu Chawla. I think she's also part of the endometriosis Society of India, and also FOXY, and then you have Asha Rao. So that is a fabulous galaxy of people that you have today to speak about in this. I'm sure it will be a great success. Thank you once again for having me. Thank you so much for your words. Thank you. So welcome, and I'm sure it will be great. Everybody is going to enjoy it.
Thank you so
Thank
much.
you, ma'am. Thank you.
Thank you for
Thank you.
always being there.
Thank
And I think Dr. Lakshmi, have you given her a call?
Ma'am का phone no reply आ रहा है, तो she's not replying.
I think then we will wait for her to come and take her blessings afterwards. And madam, with your permission, Sunita ma'am, can we, ma'am, would you like to have give us a few words?
No.
Also, wisdom?
No, Monica.
Ma'am,
Everyone has spoken so beautifully. I think it's an academics. So let's start with academics. No issue.
Okay, ma'am. Thank you, ma'am.
So
And
just
we will take Nandita and Lakshmi whenever they join. They can always have their words.
yes. Ma'am.
Lovely
So,
to see Sujata and Asha. Back to you.
Yeah.
Same
Lovely
here,
seeing you,
same here.
Sunita.
Lovely to see you. So
Sunita
nice and
looks.
relaxed.
Yeah, I was going to
Lovely.
say that.
I just told her, you know, OT on Tuesday, I worked till late evening,
Ah,
but that's okay.
In spite of that, you are looking fresh and beautiful
that's
and
what
ever
I'm
smiling.
saying. That's all.
Yes, that's the
Gone are
beauty
those
of
clouds of election.
yeah.
In
Out-
between OT, little bit of uh, freshening up and looking great.
Looking out.
Yeah. I
So
think
we-
great responsibility on ma'am's shoulder, Isar and Foxy, So
Yeah.
she has to be, confident and super,
we have seen Madam going through such a campaign that now I feel that Sunita ma'am is like anything impossible she can achieve.
Let's start academics, dear. Please.
So,
Yes, ma'am.
so I
I'm
hand
getting
over
very
the
awkward.
Thank you, ma'am. And without wasting time, I hand over the program to my coordinator, Dr. Manisha Jain, who is also the treasurer of Obstetrics and Gynae Society of Bhopal, a very active girl who is working in our team. And this is the first time she'll be coordinating ISAR Perfection Episode 8. So congratulations for joining the elite club of ISAR Perfection, Dr. Manisha, and
Thank
welcome.
you.
Please start the first session right away.
Thank you so much, ma'am. Without much ado, with the blessings of the God Almighty and all the dignitaries present here, Dr. Sunita Madam, Sujatakar Madam, and Asha Rao, would like to proceed with our academic event today. And for the first talk, we have Sunita Madam herself. Madam would be speaking on adenomyosis and infertility. And for that, to chair the session, we have with us Dr. Bharti Telly Shetty Madam. She is professor and superintendent in the Department of Obs-Gynae, Tirupati, Government General Hospital. She has many awards to her credit, the Best Research Paper Foxy 2009 and Best Obstetrician Award of State of Andhra Pradesh 2020. Her main area of interest are menopause, palliative care, and antenatal care. She's conducted training programs to medical and many postgraduate and undergraduate students for more than 33 years. And she has a project to her conducted NTR-UHS on screening and molecular diagnosis for human HPV virus in rural women around Tirupati in March 2017. I welcome you, ma'am. She has many publications to her credit. Next chairperson, we have Madam Dr.
Nirmala is not joining. She has some commitments. So, yeah.
Next is Dr. Captain Shesha Sai Tirupati, sir. He is MD Obs-Gynae from FMC Pune. PG Diploma in Human Rights from SV University Tirupati. Worked in Army as captain for more than 5 years. Worked as professor at Government Maternity Hospital, SV Medical College Tirupati. Presently working at Sukanya Hospital, Nehru Nagar near Jyoti Talkies Tirupati. FP Commissioner AP Government. Recognized laparoscopic surgeon and recognized teacher for the laparoscopic training center at GMH Tirupati. NSS program officer at SV Medical College Tirupati. Has served in the capacity of Secretary Tirupati Obgyn Society for 20 years and as President for Chittoor Obgyn Society. I welcome you, sir. Over to chairpersons. Thank you. Are they there, ma'am?
Chairperson, yes. Dr. I saw.
Shall we?
Dr. Nirmala message that she'll not be joining. I think
they're
Dr. Shalini, Dr.
I can see Dr. Shesha Sai joined in.
Maybe.
But I think if we continue, that's okay. Monica?
Okay, ma'am. So, ma'am.
We
okay,
have you, Randir, Manisha herself, so that's okay. Okay?
Yes, ma'am. Dr. Shri Krishna Sasi is joined, no? Yes, he's muted.
Yeah.
Yes, ma'am, sir has joined.
Yeah. So, sir, are you there? Can you hear us?
You know, तेरे card पे ना 4:30 लिखा था.
Yeah. No, but ma'am, everybody was requested to join, ma'am, because all of you were there. No? Okay, so probably people have logged in and not joined. Ma'am, you can start with the talk, ma'am.
Yeah.
So we start with the first presentation by Dr. Sunita, ma'am.
Allow me the screen share, no?
Doctor.
Let's see. Tech team, madam, can you share the screen now?
Yeah.
Yes,
Ed-
ma'am, she can.
Yeah, ma'am, please.
So good afternoon, everyone. And thank you, Randhir, Monica, for making me part of this beautiful ISAR Perfection series. I think it's going so well, and the topics which you design, choose, are always, the point of attraction for everyone who chooses to be with the academics. So thank you for being there. And let me start saying education is a progressive discovery of our own ignorance. Every time I prepare a talk, I realize that I have learned a lot in that. Adenomyosis and infertility, solving the dilemmas. This is topic very close to my heart because I work very much on the adenomyosis, and I'll share my few important personal work also during the talk. We all know that adenomyosis is still an enigma as we are not aware of the real reason of this disease. But we also know that certain facts based on which the present treatment modalities of it is designed. When do we call adenomyosis? The heterotypic presence of functioning endometrial glands and stroma within the myometrium, at least 2.5 mm deeper to the basal layer, then it is called adenomyosis. It may be a localized, that is adenomyoma, or diffuse adenomyosis. It may be associated with endometriosis, myomas, past history of uterine surgeries, or past history of DNCs and MTPs you may get in the cases of adenomyosis. How do you diagnose adenomyosis apart from the history where pain and the fertility, two important issues? Transvaginal sonography is the first line of treatment. You can see that there is a globular mass there away from the cavity, and it doesn't have a capsule. So 3D sonography, very easily you can differentiate with absence of capsule than that of the fibroid. And I think even those who are doing level 1, level 2 sonographies will be able to do. And if not, then MRI becomes the line of treatment. We all have understood the chronic inflammation associated with it, that is tumor necrotizing factor alpha and interleukins. These are the inflammatory reactions. These are the inflammatory reactions in lymphocytes and proliferation of the endometriotic cells outside its normal zone. That is what else happens here. I'm not going to go much in a pathophysiology because I want to discuss much in detail about the treatment of adenomyosis with infertility. And why that is important, if you see many publication, this is very recent in 2021, a beautiful meta-analysis which was published, which gave a differentiation between adenomyosis and fertility, 43% reduction in a clinical pregnancy and 3-fold increase in a miscarriage rate. That is huge. And it may be Samta, I'm in a talk. After 20 minutes, I'll talk to you. Recent meta-analysis on the impact of adenomyosis, that is what they have shown. And the presence of deep infiltrating endometriosis and adenomyosis are that is the reason why there is a adverse obstetric outcome. And some observation have suggested that the clinical pregnancy can be as low as 11.8%. If you see this Tulandis paper on effect of adenomyosis, a meta-analysis where they have taken a primary outcome clinical pregnancy and secondary outcome into rate of implantation, ongoing pregnancy rate, live birth, miscarriage, and ectopic. But what does that says is those who are having adenomyosis, there is a significantly lower pregnancy rate, clinical pregnancy rate. There is a higher miscarriage rate. And it appears that either surgical treatment or GnRH can increase the spontaneous pregnancy rate. But Another paper, beautifully, reproductive outcome after fertility sparing surgery. Does fertility sparing surgery will help us? Now, 18 studies were included where they have said that, yes, probably the mean pregnancy and miscarriage rate after the cytoreductive surgery may be good, but the chances of uterine rupture or a preterm birth may be very high. And that's the reason, if one has to think about the surgery, everyone should consider this on case-to-case basis. You cannot have a golden rule that here you do it, here you don't do it, as far as possible in this publication so far. And I'm coming to our own publication. But before that, I would again like to take, we all know Togas has done a huge work in endometriosis and adenomyosis, and his systemic review again, that medical treatment should be considered as a first line of treatment, and excision should be only to the refractory cases. Conservative surgery may improve the pelvic pain, abnormal uterine bleeding, and possibly fertility, but at the same time, it has its own disadvantage of needing the expertise in the field and chances of rupture in the uterus or the recurrence of an adenomyoma or adenomyosis back if the patient doesn't conceive within 6 to 8 months of a surgery are the biggest drawbacks of the surgery. And that's the reason the best result, the best method of surgery is yet to be seen. So everyone knows that adenomyosis aim of the surgery is to do the debulking, at least 50 to 70% of a debulking that will reduce the tension and reduce the vascularity and may improve the fertility, pain, and menorrhagia, all the three. But unfortunately, there is no standard classification yet. There is no standardization on whom to operate on, and there is no standardization which surgical method one should operate and how we should be operating. So we just have come out with this, and I think I thank Bhopal. They adjusted my timing of presentation, and I could win the first prize, Praveen Patel's best paper presentation on our de novo work, and now it is published also in one of the international journal. I don't remember because I have done during the election time 7-8 publication in international, but one of the international journal, you will find this classification for the therapeutic purpose only in ART. It all depends upon the size of a myoma, location, and relationship. I need to even thank the COVID pandemic, because in spite of such a huge work on adenomyosis and ART, we were not getting time to collect our data, say, to work on the module. And during the COVID pandemic, when the IVF cases were drastically gone down, we had no other work. We used to sit on our data, and this is how this publication came into. So this is a proposed classification. It is in GBRA, assisted reproduction. So what is that? Grade 1. This is also, we need to thank our sonologist who gives us such a diagrammatic representation that this is how I manage for last 20 years in my ART practice when there is an adenomyoma and I'm doing a IVF. And this is how we compare the cases. And if you see less than 4 centimeter, and if it is away from the cavity, can you see that? The gray area, then it is grade 1A, and less than 4 centimeter, but compressing or the touching the cavity, we call it as a grade B. So grade 1A and grade 1B, and both we treat only with medical line of treatment. So we freeze the embryos. Before the era of vitrification, we used to give a GnRH, then used to stimulate, and then we used to do the phase transfer. And the spare one we used to do with freezing with the slow freezing. But after the vitrification came in, we never give it a GnRH or Dynogest before stimulation, because obviously it will depress your ovaries tremendously. So we do stimulation, we make the embryos, we freeze them. And then if it is less than 4 centimeter, either in away or compressing, we give a medical line of treatment. Now, here in first grade 1A, usually 3 months of medical line of treatment is enough. While in B, after 3 months, we do the repeat sonography and we confirm that the adenomyoma has regressed and it is not compressing the cavity. Otherwise, we may repeat it, the doses. Now, grade 2 is more than 4 centimeter, but away from the cavity and can be treated only with medical line of treatment. More than 4 centimeter, but compressing or touching is grade 2B. This helps me. Now, again, here, surgery is not the first choice. We always do medical line of treatment, but if resistant cases, the need for the surgical line of treatment if resistant to medical line of treatment. So we give them GnRH for 4 months, amenorrhea, and still if I found that even if the volume has come down, there may be 20-30% reduction, but if it is still compressing the cavity, these are the only cases where we do the surgery of adenomyoma. So it is a grade 2B which needs the surgery. Then comes the grade 3, that is a diffuse adenomyosis, prolonged amenorrhea of 6 to 8 months, followed by embryo transfer. But these are the cases surgery, surrogacy may be needed. So long-term medical line of treatment, but may need surrogacy at time. Avoid surgery as much as possible in diffuse, because by no way you can do a complete adenomyoma compression out from all the sides on the cavity. So for a diffuse adenomyosis, if medical line of treatment doesn't work, then probably the surrogacy, I think, very painful in today's after the ART bill, where you just tell the patient, come after 1 year or so and just see how much the volume has decreased. Because if you are not doing surrogacy, either refer the case to those who are doing surrogacy, or then just ask them to go for adoption if they don't have any family member ready to carry the pregnancy. Grade 4, localized or diffuse. It makes no difference, but it is the one which is associated with endometriosis. So if there is an associated pelvic endometriosis, we label it as a grade 4, and it needs a surgery only when the cavity is compressed, not responding, or if there is a severe pain to the patient, or there is a hydrosalpinx and which is connecting to the cavity and you need to take care of the hydrosalpinx, then only you do the surgery in grade 4. Now, surgery fund decides what are the various ways. OSADA technique, we all know, it's one of the beautiful technique where there is so much overlapping that the chances of rupture are less compared to other, and this is a triple flap technique they do. We also have modified this in a large adenomyoma, while in simple adenomyoma, less than 5-6 centimeter, you can think of doing even elliptical technique or a slice method or a hook method. So you just give an incision, core out the adenomyoma, and then do the closure. So its art of endoscopy lies in the imagination of the surgery. Adenomyoma resection is difficult. It is a tricky surgery. Preoperative planning will always help you to excel your performance, and results in terms of fertility may be rewarding, but occasionally they may be frustrating. So I'm just trying to show you a clear adenomyoma case where it is compressing the cavity. Here also, here I can give just one incision in a left upper, while here you will see I'm giving a inverted T incision. Monopolar or the harmonic are the best instrument one can use in. Here I'm taking an inverted T because it's nearly 5 to 6 centimeter, completely compressing and not responding to the medical line of treatment. Inverted T helps you, I'll show you only one video. Inverted T helps you to go in a depth and to take out the slices more properly. So first is give a serosal surface inverted T and then keep on deepening, keep on watching your uterus all the time to compare the anterior and posterior bulge. You know that you have to remove only 60% to 70%. Don't try to remove. So here is the center and I think I have achieved. Then I will go to the horizontal. Usually, if you even with the monopolar, it doesn't bleed. So when bleeding starts, you know that the healthy tissue has come. We usually do with the slice technique. It means we keep on removing the slices around 9 mm to 15 mm of the thickness should be there between the endometrium and serosa to avoid the rupture of a scar during pregnancy. So I'm just taking and slicing as much as I can. You can have a bipolar shearer also. Nowadays, it has replaced our harmonic in quite a lot. And you can see, you can just excise beautifully and remove the slices. I'll just fast forward it. You can see I'm removing the slice. Once this slice is removed, I will just go and remove in opposite side also. Try to use a cutting current as much as you can. Now, the next slice, I feel I can just still go. I don't like to open cavity at all. I will never open the cavity. And that's why even the literature, the publication, the evidence says around 1 centimeter of the thickness you should keep. Here, our aim is to do the debulking and also to decrease the vascularity, and that's it. What is important is a suturing. So once you remove in these slices, always remember when you do in a 3D laparoscopy, you will always have a huge magnification. So be careful and try to do the suturing very properly. So you do inverted this vertical line, you do the center very well and take the horizontal layer also beautifully. So this is what is very important to do your very good closure as an end result. Now, sometimes association of a uterine wall thickness, I was telling you, this is a beautiful article which is published in 2016, and they have taken a total of 23 women, and they found that the wall thickness remaining should be 9 mm to 15 mm. I usually like to keep between 1 to 1.2 centimeter always. Sometimes you may have a tricky adenomyoma. It is protruding inside the cavity. So instead of going laparoscopically, you can enter hysteroscopically. It is like a septum inside, but don't cut in the center like a septum because it will retract to the anterior fundal and posterior wall, and you will have more larger area of no implantation zone on anterior fundal and posterior. So what is important is you need to remove. This is a Varsa point, which is the first bipolar energy which has come in India in early 2000. And this Johnson & Johnson have taken out in the market. I get it from European countries now. But what was the importance of this bipolar electrode was it dissolves the tissue beautifully. The only drawbacks were, one, you don't have a histopathology, tissue for histopathology, and second, it forms lot of bubble. But over the period, you learn your knack of sucking the bubble slowly by keeping a little outlet on with the little pressure, not fully on. And this is what adenomyoma. So first I did a frame on all the sides, anterior, posterior, and lateral, so that I remain within the frame and no chance of going too much anteriorly or posteriorly. Sometime doing hysteroscopy, you may get carried away. So this frame of rectangle helped me to see to it that I'm always in the center and on adenomyotic tissue. And once you dissolve that, now you were knowing how much, you also can see the corneal openings. So that much is the depth of adenomyoma which is protruding, and you can keep on doing further. you can keep on dissolving all. Fibroid and adenomyotic tissue, you can very well differentiate from the rest of myometrial tissue. So this is how. So performing hysteroscopy is like a painting on a canvas. I feel everyone should be those ART consultant, either they themselves or in their team. They need to have an excellent endoscopic surgeon so that they optimize their ART result. And sometimes by doing a good endoscopic surgery, they can avoid ART for their patient. So just few cases to summarize. Now this is 2B, where it is more than 4 centimeter compressing the cavity, and 2A is more than 4 centimeter but not compressing. This is also 4B, more than 4 centimeter, but you give her this patient a treatment with the medical line of treatment. You will see that it has shrunken. Now see this one case. This has a polyp in the center and an adenomyoma on a posterior wall, little bit encroaching the cavity. Can you see this? This is an adenomyoma. This is a schematic diagram with the polyp. Now for this patient, I did a polypectomy and I gave a medical line of treatment for a adenomyoma. And you see how the adenomyoma got shrunken away. It has come out from the cavity. You can see even here, I can see the cavity so well, and the adenomyoma is shrunken. So no need of a surgery in this case. Always try with the medical line of treatment. You got a 30-40% reduction in the volume. You got it a compression out from the cavity. That's a wonderful thing. Plan the embryo transfer for this patient. While this is for 2A, where more than 4 centimeter but away from the cavity. This is our grade 3 diffuse adenomyosis, and this is along with the endometrioma. So this becomes our grade 4B, where there is an associated endometriosis. This is again 2B, where I will do the medical line of treatment, but I do keep in my mind and I do counsel the patient that probably I may need a surgery for her if medical line of treatment doesn't work. If you counsel your patient very well that I'm trying medical, but if it doesn't, and of course this diagram helps me to explain them the pathology very well, and also the compression on the cavity, which will give me the failure. So it's not only the compression, I'm talking about the mechanical compression, but sometimes we will talk about implantation in endometriosis, how the endometrial receptivity will get altered, how Th1 immunity goes high and Th2 is lowered, which affects I'm sure in further lecture, someone may be talking about it. So this is a 4B, again, medical line of treatment, but if doesn't fail. Now, after 3 months, when I do the repeat sonography, if I see that 30% reduction, though the size has completely not, but there is a good volume reduction, I do extend the medical line of treatment before I think of surgery. And this is obviously 4B with the endometrioma. So be thankful for your each new challenge. I think these are the cases which helps us to understand it better. Your sonologist helps you to make the complete pathology picture clear, and then it helps you to decide further. So it's a team which has helped me together. Some woman needs to be treated, others don't. Important is wisely find out which one. Treat every patient like your daughter or daughter-in-law, what you will do. Don't aggressively just operate before embryo transfer. In infertility, individualization of each case is important in order to achieve excellent result. Thank you.
Thank you so much. It was so beautiful, ma'am. And with your permission, your chairperson, ma'am, has joined. Sir was there, but you had all just started the talk. So,
Dr. Sheshasai, namaste. I always spoken to him on phone I promise, and he has promised me to give a Tirupati VIP darshan. And Shesha says, I don't know whether you people are in his group of professors. Amazing knowledge, amazing publication, amazing contribution, and a zeal to teach each and everyone as much as you can. Wonderful to see you, Shesha Sai.
Thank you, ma'am. I had very nice presentation of yours. Really great, madam. You did very excellent way.
Thank you.
Thank you, ma'am.
Thank you.
Sunita, Dr. Asha Rao here. It was such a wonderful presentation. We can see the level of maturity it has reached. I mean, when to manage medically, when not to hurt them unnecessarily, and when to do the surgery. It was discussed so beautifully.
Yes, ma'am.
Hats off to
Thank
you.
you. Thank you.
Madam, this classification, Dr. Sunita's classification should now come in the textbooks because it is treatment based.
What happens? Yeah, Monica.
Yes,
Complete, sorry.
So no, ma'am, if it comes to the postgraduate textbooks, definitely when these PGs, they leave medical college, they'll know. Because what I learned in this webinar is what not to do is important rather than.
You know, Monica, I'll tell you why this has come. Of course, COVID has given me a lot of time to sit with our all work and to go through our data. But I'm being an endoscopic surgeon, president of IIG. I moved across, and all endoscopic surgeons are my friends. They are great surgeons, but unfortunately, when they are only endoscopic surgeon and not an IVF consultant, they do aggressive adenomyoma surgery in a patients of ART, where otherwise you are going to do the IVF. Adenomyoma surgery becomes left and right. Now they are good surgeon. In their hands, rupture uterus is not probably the scenario, but they have hundreds of followers. And those people also start doing left and right adenomyoma resection, and these women land up in uterine rupture. Rupture uterus, we all know the incidence of 6 to 8% is globally. No one can say I'm a great surgeon and it will not happen. So what is important is this rupture uterus with the young generation has to be stopped. And the only way we thought is we don't operate. We are a combination of ART endo. We don't operate. We think 10 times before doing a adenomyoma surgery. Why not to come out with our own classification, the way we manage the patient? Because on day one only our protocol is final. When the patient's diagnosis is made, even before we go for the egg pickup, our whole protocol, how we are going to do the IVF protocol, Freezol, GnRH or Dynogest. Nowadays, I'm loving Dynogest. It gives a wonderful reduction into the volume, is as good as surgery. You continue it for 4-5 months and you see that 50% you reduced. So with surgery also 50 to 70% you are supposed to do. But you avoided one big scar. As it is after the surgery, I'm not going to do the embryo transfer for 3 months. So time is not at all you are wasting while giving a medical line of treatment. So I know I enjoy surgery. I enjoy the way I will close these flaps, but at the same time, I see to it that I avoid surgery as much. Only during pregnancy, we all know they need a little more careful obstetrics because these patients always have chances of missed abortion, but more than a missed abortion, IUGR, oligohydramnios is very common with adenomyosis when you give a pregnancy.
Perfectly told, ma'am, Sunita ma'am. And nowadays, because to avoid the ruptures and all, lot of allegations, no, madam, litigations that Consumer Forum, and also we have to be a little cautious.
Careful. Madam, with chairperson's permission, can I ask a question? Can I ask?
Asha is saying something. Yeah, Asha.
Sorry. I just want to say, Dr. Sunita, that Dynogest does give volume reduction, but if you give GnRH, and in resistant cases, GnRH with aromatase gives much better volume reduction. 60%
agree.
volume reduction in 3
I
months.
agree. And aromatase will help us to shift estrogen dominance to the and decrease the progesterone resistance, which is the main factor in endometriosis, which affects the endometrial receptivity.
Very nice.
Madam, what is your opinion about the combination of Dynogest with estradiol valerate? The combination tablets which are coming 21-day packs.
I don't give those combination vagare. When I'm giving a Dynogest, I'm giving a Dynogest unless patient is complaining hot flushes too much to me. I have not had a patient complaining because I really don't want estrogen dominance. Whole pathophysiology of endometrium is the estrogen dominance and progesterone resistance, which happens in endometriosis. And we want to shift it.
Madam,
That
what is the
where
gap?
the aromatase inhibitors are playing important role. Also, I have seen the publication of metformin because of its anti-inflammatory role. There are people who are saying metformin also as one of the medical line of treatment, though I have never used it.
Madam, how much gap do you give between stopping Dynogest and doing your FET?
Okay, so suppose if I want to stop the Dynogest today, usually Dynogest gives a beautiful amenorrhea, maybe hardly spotting comes. So suppose today I stop, I put the patient on 21 days low. I'm just giving one talk. I'll call you in 2 minutes.
Yeah.
Dynogest, if I stop, then I start a low dose OCP like Miliana or Novelon. 21 days, I give a 1 withdrawal bleeding and then I start the Progenova. I usually don't do the natural cycle transfer. I do the hormone replacement always. So Progenova, 4 milligram 3 times or 2 milligram 3 times, depending upon her body mass, I decide.
So nice, ma'am. The Dynogest, the tip about Dynogest, I'm sure it's going to benefit many of us.
Usually.
And Monica,
You
if you can
3
interrupt
months
for 1
to
minute.
4 months, get one nice withdrawal bleeding and start.
Yeah. Thank you so much. Yes, ma'am. Asha,
Ashita, if you can interrupt for 1 minute. Monica, your question was Dynogest plus estrogen combination. Does it work? It's not ideal because your volume reduction will not be as much as pure Dynogest.
Yeah.
Even with endometriosis, they have proven that if you just give Dynogest, the volume reduction of a cyst is much more than giving the combination of Dynogest plus estradiol.
I agree.
The antagonist, if you give with estrogens, you do not have bone loss, but the volume reduction of fibroid is much less.
Yes,
so whenever you put estradiol with this, the volume reduction is much less. So you do not do that.
Thank you, Asha ma'am. Thank you, Sunita ma'am. Over to Dr. Manisha for the second session.
It's always pleasure listening to you, but we have to move on to the next session. And for that, we have Dr. Anu Chawla ma'am all the way from London with us. And she'll be talking on the ASHRAE guidelines of 2022. And to chair her session, we have the chairpersons as Dr. R.C. Krishna Sessi sir and Dr. Venkat Raman sir. Dr. R.C. Krishna Sessi sir is the foundation member of the FOGSI Anandpur and is currently executing the duties of Secretary AOGS. And he has done a lot of work on trabectomies and performed lakhs of laparoscopic trabectomies as part of national and state suggestion programs. Next, we have with us Dr. S. Venkat Raman sir. He is presently working as professor and HOD of Obscenia Department, Kurnool. He is also a laparoscopic surgeon and has performed 50,000 DPL installation procedures. Welcome you, both the chairpersons. Over to chairpersons.
Thank you very much, madam. Now I introduce Dr. Anu Chawla, madam, and she is the fertility specialist and London fertility clinic she is running and chairperson at endometriosis committee FOGSI. She is a very good laparoscopic surgeon and with vast knowledge and experience woman. So we invite her and we can take her message. We welcome you, madam, for your speech on management of endometriosis in infertility.
Thank you, Dr. Shashi and Dr. Ramana. Hello to everybody, and it was so delightful to hear the previous lecture from somebody who I very, very humbly pay my regards, Dr. Tendulkar. And we have a fantastic leader in her form, especially a woman leader, so very special. Yeah, I want to do a little correction here. I was trained formally by Dr. Rakesh Sinha, but I do not anymore do the laparoscopic surgery, but I do my own hysteroscopies. So for the past 14 years, I am practicing as the consultant in reproductive medicine. Yes, so currently I'm working at London Fertility Clinic. I'm the scientific director of the clinic. So I am happy to, if you allow me to please share my screen. Yes. So today's presentation that I have, and I'm speaking from Mumbai. So I'm today very much here in India. So basically, I have divided the presentation into two parts. The first part is the guidelines, and the second part is basically the updates and the newer trends. So I have focused on what do we have new to talk about, especially in this last 6 months to 1 year. In the research publications, what is being most popularly talked about. So I begin with this first highlight, which is basically that when we go through the research papers, we see that one of the major, when it comes to endometriosis studies, one of the important research barrier is that although live birth rate is the most relevant outcome as we know, but the most of the study that we come across, actually the outcome parameters that they have considered is the biochemical or the clinical pregnancy rate. So if anybody is doing a study on endometriosis, I would really flag this, that if you consider live birth rate as your outcome parameter, there is a higher chance that your papers might get accepted to be published. So keep that in mind and focus on the live birth rate rather than clinical pregnancy rate, which actually is going to create a lot of bias. In infertile women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility, is a line taken from the guidelines itself. So in the beginning, I'm going to just highlight from the perspective of fertility, what are the important points that in September 2022, they have highlighted and they have edited and given more focus on that. Based on the results of the Cochrane review, suppression of ovarian function by means of danazol, GnRH agonists, progesterones, or OC pills to improve fertility in women with endometriosis is not effective and should not be offered for this indication alone. The next thing is that women seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance the future pregnancy rates. In infertile women with endometriosis, clinicians should not prescribe pentoxifylline or any other anti-inflammatory drugs or letrozole outside the preview of the ovulation induction to improve the natural pregnancy rates. The operative laparoscopy could be offered as a treatment of, so I want to really bring your attention to this point that obviously laparoscopy has been taken out as the gold standard, but at the same time, I want to highlight that we have to always stay at a nice balancing point for an individual case. Getting too conservative might actually sometimes waste a patient's time, and getting too aggressive might actually compromise and again waste a lot of time getting the injury healed, which is caused by the surgery. So it is very important that you still go for individual decision-making rather than blindly following the guidelines. Although my topic is reiterating the guidelines in my first part of the topic, I would still say guideline is a guideline. It's not a law. So you can break it if you think that in this case, you actually have a rationale and you can explain the reason of what you're doing. So it is offered as a treatment option for endometriosis associated infertility in the revised ASRM stages 1 and 2 of endometriosis, as it improves the rate of ongoing pregnancy if, for example, a previous history of multiple miscarriages and you don't find any other reason. So very individualistic approach is still the most important bespoke treatment that you can do for an endometriosis patient. We know it is the last thing, somebody who knows endometriosis knows the gynecology, I think. So I've heard, this is actually a quotation by somebody, I can't remember the name. So we know that it is the test of our clinical acumen that we have gathered over the years. So the research recommendation in patients without a clear indication for ART, the value of surgery for ovarian and deep endometriosis and its effect on the natural pregnancy rates should be evaluated. Such studies should consider patients' age, endometrioma, bilaterality and size, previous surgeries, adenomyosis, and other factors affecting the fertility. Women with endometriosis can be reassured regarding the safety. Now, this is another point that very commonly our patients ask us, that so basically, is this ART itself going to cause a problem for because we, as Dr. Tandulwarkar already highlighted this point, that we always have to remember that endometriosis principally is an estrogen dependent situation. So patients do have this concern. So, but they can be assured that regarding the safety of ART, since the recurrence rates are not increased compared to those not undergoing the ART. Both the protocols can be offered based on patients' and physicians' preferences. Obviously, I'm not talking about any other protocols because these are the two commonly followed ones, as no difference in pregnancy or live birth rates have been demonstrated. Women should be counseled for their chances of becoming pregnant after surgery. To identify patients that may benefit from ART after surgery, the endometriosis fertility index. Now, this is another point which is very highly emphasized in the newer guidelines. But I have fortunately been able to speak about few authors of the guidelines, and not every author feels the same. So there is one lady who does it, and because of that, it has been incorporated. We all know that not many people are doing it. It's a good practice if you can do it. But if somebody is not doing it, let's not antagonize that person too much. So should be used as it is validated, reproducible, and like Dr. Tandulwarkar was showing very beautiful schematic diagrams. That is something which David Redwine also used to do, who recently unfortunately passed away. So schematic diagrams and record keeping, and those things are going to help us reproduce the discussion of the patient in the MDT, in the multidisciplinary team meeting. So the schematic diagrams are important as well if you are not doing the EFI. So results of other fertility investigations, such as their partner's sperm analysis, should be taken into account, because we always have to make sure there's no confounding factors. Women with endometriosis can be reassured regarding the safety of ART. I'm sorry, this is a repeat slide. Yeah, this one. So ART was not associated with increased endometriosis recurrence rate. A weak recommendation was formulated to inform and reassure patients. The use of antibiotic prophylaxis at the time of the oocyte retrieval in women with endometriosis seems reasonable and is recommended as a good practice point. We all have come across either our own or some colleagues' patient who had some infective post-operative complication when they did egg collection in endometrioma. So never forget to give antibiotics to these patients. You might not be giving to every patient. There is no evidence of whether IUI or ART is superior in these women. Now, I just wanted to touch those highlights. Now I'm coming to the second part of the presentation, which is what are we talking about in the recent papers? So what is the new discussion in most of the recent papers? So some important, so they're all different. So I've not mentioned the date, but let me tell you, they're all within the last 6 to 10 months of publication. So none of the papers that I'm going to quote is older than 10 months. So that's why I've taken the dates out, because we want to keep the focus on the points. So race, ovarian responsiveness, and live birth. So this was a very good paper. This was produced by the team in Pennsylvania. And the conclusion was, Black and Hispanic patients have higher ovarian responsiveness to stimulation It could be related to some receptor sensitivity during IVF, but do not experience consequent increase in the live birth rate. Factors beyond differences in responsiveness to ovarian stimulation need to be explored to address the racial and ethnic disparity, which we see it is such a vital point everywhere. So we should not just blindly follow the numbers given by a study done in very different country than the racial or the ethnic population of the place where the doctor is practicing. Another point was advances in the endometriosis therapy. So uptake. So when we actually treat the patients, uptake of systematically delivered magnetic nanoparticles by spontaneous endometriotic lesions. So this basically, like how we already have the vitamin D nanoparticle delivery used to increase the bioavailability, which is one of the popular methods actually now in patients who do not respond to normal vitamin D doses. Sometimes they do respond to this method of medication. Similarly, KDR-directed nanoparticles accumulate in the endometriotic lesions, not adjacent organs commonly associated with endometriotic disease. Iron uptake by the liver represents a potential off-target effect of high doses of iron oxide here. The impact statement of this study was that basically this could be a novel mode of delivery of therapeutic molecules to the endometriotic lesions, like how we were just talking about giving the progesterone support to antagonize the estrogen-related side effects. We would not have to need to talk about that. But anyway, we are not giving these medications more than a few months. So I think it is largely safe anyway. But this is one of the new things coming up. The next thing is that severe pain symptoms do not impact. So somebody who's very symptomatic, usually the question is that because it is so, apart from the symptomatic treatment, coming to this patient's fertility treatment, generally the patient will ask that given the fact that I'm so symptomatic, is it going to have an effect on my ART outcome? And we generally do not have a very clear answer, but endometriosis related pain should not be a reason to systematically refer infertile women to surgery if the medical treatment elevates. So this is more important part of the sentence, because we know there are only two criteria where patients who have been planning for fertility treatment, they will need surgery only in two scenarios. The first is if the endometrioma is coming in the way, it is having the accessibility issues, or if it is too symptomatic and not alleviated with the medical management. Coming to this, Dr. Tandurkar was just mentioning that somebody might pick up. So I have just briefly touched this because of the limited scope of the presentation. So see, obviously, we know that the inflammation and immune system, so immunology and inflammation are two important aspects. Inflammation more so, but immunology is questionable when it comes to how endometriosis has implications to the outcome parameters. So I think it can be a whole separate talk, and I'm happy to do it in future if we want to talk in more detail about the treatment and investigation. More important is the investigation. So investigation, both the uterine factors and the blood factors. So some teams in Chicago feel that we should just focus on the uterine factor. Some other teams in Paris or other parts of the world, they feel we should focus on the blood factors. In our practice, we offer the immune treatments to such patients only after the failure of 2 cycles of properly done IVF in a case of endometriosis, and then we offer the patient the option. It's not mandatory, because now we are shifting from evidence-based to experimental-based. So the moment we talk about immunology or anything related to that, we have to tell the patient, first of all, that now if they want to move towards that, they are putting money into not the evidence-based, but the experimental-based therapies. And first of all, it could be very expensive to go get those tests done. So identification of immune predictive biomarkers of endometriosis using non-invasive immune screening test in association with machine learning model. This is one of the papers recently published by this team in New York. And also, this was actually a combined paper from Brazil, New York, and few places. So the conclusion was these findings suggest that our non-invasive immune screening tests combined with machine learning modeling has the potential to accurately predict the presence or absence of endometriosis, first of all, offering a promising approach for early diagnosis and management of this complex condition. Non-invasive immune test identifies potential predictive biomarker for endometriosis. We know a lot of work is being done in France by Vice President of FIGO, the past Vice President of FIGO, Philip Decombe. He's doing this work. Also with our own Ramani Devi from South India has become a part of that study. So a lot of people are doing different things. He's working on the mRNA-based technology. So diagnosis in the subclinical areas where we think the reason of infertility is unexplained, but actually 10 to 20% of them are clear cases of subclinical endometriosis. That is the area where it will help. We know we have newer drugs very much used for many years since 2000. I went to in a unit in New York in 2014. They were already using elagolix tablets as antagonists in IVF cycles. So long-term therapy of elagolix plus Advec therapy in women with endometriosis associated pain for 48 months. So this was basically a safety update on the bone mineral density data. And the impact statement was endometriosis related pain should not be a reason to systematically refer infertile women to surgery if the medical treatment alleviates the painful symptoms. One mineral density after another similar paper, so I've kept them together. This is for relugolix. One mineral density after 2 years of treatment with relugolix combination therapy and 1 year post-treatment follow-up in women with endometriosis. This was called SPIRIT program. Again, combined teams of Australia and China and New York did this study, and Switzerland. The conclusion was in women with EM-associated pain related with this particular markers, who changes basically this drug, what is it called? Relugolix, along with another salt, whose changes in bone marrow density were evaluated after treatment cessation. There was evidence of recovery regardless of whether they maintained or lost BMD after 2 years of treatment. Now, the impact statement was with up to 2 years of data on changes in the bone mineral density with the relugolix on treatment with 1 year after treatment discontinuation, the benefit risk profile of the drug remains favorable in women with EM for longer term of treatment. Now, very interesting. We all are talking a lot about melatonin. Apparently, it has a lot to do with many systems in our body. Few new things that we are talking about, out of them, melatonin and pituitary regulation, how the pineal gland works, how pituitary gland works, how melatonin works. So this is another area of research. Melatonin overcomes the toxicity. So basically, oxidation is an important part of the outcome parameters. So something, it has a clear cause and effect relationship when it comes to the outcome of ART in such patients where ultimately we have more oxidant accumulation. So melatonin overcomes the toxicity of the oxidant accumulation in the follicular fluid of women with endometriosis and prevents the metaphase 2 mouse oocyte microtubule organizing center deterioration. Beautiful study. The impact statement was treatment of oocytes in inflammatory diseases. It could be anything actually, but endometriosis was studied. Anywhere we see inflammation, it could be an extreme stress situation also. It could be anything that causes a lot of inflammation in body. With antioxidants such as melatonin may alleviate the harmful effects of oxidative stress in the context of the ROS, RNS, and or free metal. clinical application of these measures may help to improve fertility outcomes in women with endometriosis that suffer gamete quality deterioration. We all had those conversations where we sit down with the couple and tell them, oh, your oocyte quality has a problem, your sperm quality has a problem. So maybe we are going to get some more light in this area about how exactly to troubleshoot such situations. Effects of dysregulation. So this is another thing. So everything in life somehow is connected to insulin sensitivity. So just now, Dr. Tendulkar mentioned the role of metformin in her lecture. And again, this paper is actually reiterating something like that. This is a paper from China. So effects of dysregulated glucose metabolism on the occurrence and the ART outcome of endometriosis patients. The impact statement was that the effects of dysregulated glucose metabolism on the occurrence and ART outcome on such patients, there was a prediction model based on the metabolic indices to evaluate the possibility of presence of endometriosis was established, representing a promising non-invasive method to predict endometriosis with patients with known pregnancy history. There's something mistaken, but you can maybe take a screenshot of this. I will again also read the conclusion. So endometriosis patients had abnormal metabolic indices in which serum glucose and serum insulin levels are related to the occurrence of endometriosis, the number of retrieved oocytes, and the occurrence of gestational diabetes mellitus. A prediction model based on the metabolic indices to evaluate the possibility of presence of endometriosis was established. While those metabolic alterations had no effect on their ART outcomes, the incidence of pregnancy and neonate complications in endometriosis. So basically, there is some maybe, so as far as I'm aware, the only one drug in the whole pharmacology book which said that increases life is metformin. So I have never seen any massive harmful effect of metformin apart from acidity, which can be easily managed. So maybe that also has some role. Characterization of, again, this was touched by her in her presentation. So Bachither Singh is some author which I have come across a lot. He has been doing a lot of papers on endometriosis non-stop for 10 years, maybe more. So characterization of progesterone resistance in a prospective cohort of surgically confirmed patients with or without endometriosis. Conclusions, contrary to the expectation clinically, and I'm sorry, I'm known to to oversight my time. So if my time is up, please stop me. So contrary to expectation, clinically apparent progesterone resistance decreased with higher revised ASRM disease severity score. Patients with deeply infiltrating peritoneal and nodular lesions were found to have a higher percentage of progesterone-resistant disease than patients with ovarian endometriosis. The impact statement was, determination of progesterone-resistant status may provide insights into disease pathophysiology and guide development of targeted precision-based clinical therapies to treat the patients. Now, analysis of, again, one more paper on inflammatory cytokine profile of the follicular fluid from such patients who are known cases of endometriosis. And how does it impact the sperm motility? The cytokine array revealed there are 6 differentially expressed cytokines, and they are indicative of the pro-inflammatory environment, and they could contribute to the decreased oocyte quality, embryo formation, and implantation. The 6 oocytes the 6 cytokines overexpressed in the follicular fluid of the patients with endometriosis have also been associated with these 3 things, which are PCOS, fibrosis, and sperm motility. The impact statement was the findings from this study provide potential underlying mechanism of how endometriosis can lead to subfertility. Again, one more paper from China in which the controlled ovarian stimulation in endometriosis patients was studied, and it was realized that Dynogest pre-treatment for patients with endometriosis before controlled ovarian stimulation could be a suitable treatment option for decreasing gonadotropin dose and stimulation days without any negative effect on the control ovarian stimulation outcomes. Now, this is another so this is a question and reply going on in the form of published papers in the fertility sterility. So it was very interesting read, highly recommended. Recently, two people have been talking to each other through papers. One is Paul Pertia, who has published incredible amount of work in endometriosis recently, including that paper, if you all remember, in which he said that as long as you have a euploid embryo, you can actually expect the same outcome as a patient with no endometriosis. Now, he published a paper in which he stressed on the point of progesterone resistance being the culprit. So Peter Humayden, who's a known publisher, who's a known author of many good studies, he has written a reply to his paper in which he has written that we certainly agree with the investigator's conclusion about deferred fresh embryo transfer in patients with endometriosis or adenomyosis. However, we would emphasize another side of the coin that than that suggested by them, in contrast to Paul Pertia, as seen from a basic physiological viewpoint and recent clinical research on both endometriosis and adenomyosis. The endometrial progesterone receptor resistance is a key point, and this resistance to progesterone can be alleviated by reducing circulating and local, the circulating and the local estrogen, and respecting a higher serum progesterone cutoff level at the peri-implantation phase. Again, Paul Pertia has replied to him, sorry for this, by writing this. The same is actually needed for the hypothesis proposed by Cozzolino, that treatment with an aromatase inhibitor, which again Dr. Tandulwarkar has already touched, so she has covered very important points already. In addition to the pituitary suppression with the GnRH agonist, reduce serum estrogen levels and improve the clinical outcome. This is quite promising, but larger studies are required. Now, endometriosis and pregnancy loss. This is very important. Very commonly we come across this situation, and generally we don't have clear answers to give it to our patients. So therefore, we firmly believe that investigations. So basically, the point is, the summary of this paper is that most of the papers do not consider the confounding factors. So blaming endometriosis for poor pregnancy outcome in the form of bad OBS history or miscarriage, please note it is still not established, because if we have gone into the detail of those studies, none of them were free from massive confounding factors. So any one of you, if you want to maybe randomize with a lot of effort and create a paper like this, definitely it will be accepted to publish, because we don't have anything like that. So patients are diagnosed with endometriosis are more likely to have the pre-receptive endometriosis. So ERA in general, I am not a big believer, but only in case of endometriosis patients, I do ERA sometimes if the patient agrees. So there may be a role of checking the phase or in phase or out phase or receptive or post-receptive of endometrium, and only such patients may be, and additional research is definitely needed. Thank you very much for your time. Thank you. And I also want to thank the organizations, which I forgot in the beginning, because obviously we were told to just focus on academics, which was rightfully so. So Dr. Tandulwarkar, Dr. Nandita Palshetkar, Dr. Sujata Kar, Dr. Monica Singh, Dr. Randhir Singh, Dr. Manisha Jain, Dr. Asha Rao, my previous committee chair, so now I'm taking over from her very respectfully, and Dr. Lakshmi Srikhande. Thank you, everybody who listened to this. Thank you very much. You can write to this email if you have any questions for this presentation or any other questions otherwise. Thank you very much.
Thank you, madam, for your nice presentation regarding the treatment. Thank you, madam.
Dr. Anu, it was a very lucid talk. Earlier, I thought it's just the guidelines, but you added those studies and you gave tips as to what all in research and methodology can be accepted. Though I have attended ESHRE workshops on research methodology and listened to stalwarts, but still there's always a helpful tip. But definitely, like doing a study now on ERA just to get your paper accepted might be good for a big unit or maybe a very rich unit, but just to subject an Indian patient to ERA to assess receptivity would be a little costly proposition. What are your comments?
No, I'm never asking you to anybody to do a test
No,
on
but
ERA. I
still,
already
but
said
if
I'm not a big believer of ERA.
yeah,
But
but if you
only,
do suggest in India, because you are taking over as chair,
Yeah.
endometriosis committee, it the responsibility comes directly on your shoulders shortly. As to would you be in endometriosis committee of FOXI when you deal with infertility patients? Would you be promoting ERA in any way more
No.
than in other
No.
pathologies?
Now, my clear answer would be no. I will not be promoting ERA. What I will be promoting is talk to a patient a lot more than what normally people do. Tell the patient the options. So first of all, I want to just take a little 30 seconds here and say an answer which will answer a lot of other questions like this, which is that why do we always feel that we have to decide for the patient? This is a wrong thought, according to me. We are not entitled. We think we are too entitled for the patient, which is not the case. So the patient has to know and decide for themselves with the options given to them, especially in this day and age when a lot of things are not evidence-based, they are experimental in nature still. So, and trust me, patients do understand. A lot of us unfortunately think that patients don't understand, so they don't need to be told. So the most important common answer to a lot of questions like this is talk to the patient, sit with them, tell them this is the technology, this is the pros, this is the cons, this is the cost. Tell them the cost, tell them the advantage, tell them the disadvantage, and then the last, tell them the level of evidence. Tell them you don't need to tell me today, go home, digest this information, come back later and tell me you want to do this or not. That's it. Are we not going to be happy if my dentist, if I go to the dental thing and something is not clear and it could be two different opinions from two dentists. If the same dentist says that this is the technique, this is the pros and cons, this is the cost, this is the level of evidence, you take your time and come back and tell me, I think that's the way we should start practicing.
Another question, Dr. Anu, is there any role of fresh embryo transfers?
Absolutely, yes. See, my mentor is Dr. Pai. I always ask him questions like this. And generally his answer is based on common sense. There was a patient, I was very confused, and multiple times we had a discussion and the patient wanted us to decide for them after giving all the knowledge. Then see this, what I have been, processing as my very central aspect of my thought when it comes to using or not using the opportunity for fresh transfer is that fresh transfer, only one opportunity is going to be there for that cycle. If they have 6 embryos, there will be 5 other embryos definitely going for the frozen embryo transfer, but 1 embryo will get a chance for a fresh embryo transfer based on common basic sense. Now, freezing is going to subject a lot of, embryo to a lot of cryoprecipitants. So based on this common general sense, I will always give the option to the patient to try 1 fresh cycle because rest of them are anyway going to be frozen transfer cycles of those embryos of that cycle. So depending on her physical wellness, of course, after the cycle, if you ask me the data of my practice, so in my practice, the data of fresh transfers is more than 50%. And so I do promote fresh transfer unless there is a reason not to do it.
Yeah. And do you do any pre-treatment for your before your ovarian stimulation in a patient with, let's say, stage 3 revised ASRM endometriosis, do you do any sort of pre-treatment, though it is not recommended? So you just take the patient in any cycle where she seems to be okay with the ovarian reserve and AFC and everything? Or do you do any pre-treatment?
Any cycle meaning what? Meaning you are asking whether the cycle selection?
No. This patient just walks into your clinic and she is probably she is premenstrual or something. And would you just take her in the next cycle, or do you have any criteria?
So that is the rule of my practice anyway, that we never rush. The cooling off period is an essential ethical part of the practice. So we never rushed, regardless of even if the patient says that I have done everything and you start my IVF. Today is the first initial consultation. 3 days later, she's going to have periods. I will not do IVF in that cycle. This is not, doesn't matter which patient. This is the ethos of the practice. We do not rush any patient. It takes time to do consent signing. It takes time to think and decide. Not everyone has a huge knowledge of IVF. They might know about IVF, about some other points, and then they might decide that. So cooling off period of minimum 2 weeks is a part of my ethos of my practice for all patients. So I will not do it for anybody.
So when you have that cooling off period and you wait for a cycle, do you give any pre-treatment?
Yes, pre-treatments are not given to everybody depending on, so that is a very bespoke situation. First of all, the only one pre-treatment, okay, let me answer this properly. I never use OC pill for pre-treatment. I think that's not a good practice because it does two things. It increases the duration of the stimulation required. It also increases the total dose of injections required. Plus, it is not good in any form or shape, according to my knowledge. So pre-treatment with OC pills is never done. Pre-treatment with progesterone sometimes is only done if I am not available and the patient wants me to do egg collection. And the third reason of pre-treatment with estrogen is if previous cycles were not, I was not very happy with the cohort coordination or things like that, then I do use the pre-treatment with estrogen. Now, there is another thing that I want to try, which is the use of antagonists in the beginning of the cycle to create more coordinated cohort, which my friend Dr. Jatin suggested, but I'm yet to try that. I have not tried that yet, but I will see where I think it will be rightful to try that, because I don't want to try on any patient.
Dr. Jatin really speaks very highly about this protocol, wherein he's using the luteal phase antagonist, or day one antagonist, and then continuing through the cycle.
So it's more to time the cycle, and that is why I think I'm not feeling very confident.
But is Asha ma'am available there to comment? Dr. Asha Rao, ma'am, are you there?
To conclude my comment on this, the only pre-treatment which I think might be helpful based on current knowledge, unless the knowledge evolves, is estrogen pre-treatment. Right. Otherwise, you don't really need to do any pre-treatment. For example, to answer your question, that the patient has come to me and 1 month later or 2 months later, she's going to start. If there is no reason, I will not give the pre-treatment for anything. I will just wait for the periods of that month or based on the protocol.
Asha ma'am, what is your
I think, it was a lovely talk, Anu. Well done. Enjoyed the talk. And as Anu said, we did not give any pre-treatment because gone are the days, when you give this prolonged GnRH suppression, 3 months. And so we do not give that kind of suppression. Only in poor responders, sometimes we use the androgen. We also try this Progonova estrogen pre-treatment, but somehow I'm not happy with the estrogen pre-treatment. So pre-treatment is really essential for after embryo collection. Perhaps you can give a suppression of the endometriosis. It depends on the stage they are in, and then do the deferred embryo transfer.
Right, ma'am.
So when it comes to poor responders, there were two things which were concluded to be maybe useful. One was growth hormone and the other was androgens. And that's why I started doing DHEA, and I was waiting for the T-transport trial results of testosterone gel. Now I want to share. I want to share that the
what is true today is not true tomorrow.
T-transport trial has come crashing.
Exactly. So yeah, T-transport trial results have come out. We know and they are saying that it is useless.
Useless. So
Yeah,
imagine
nothing.
so many hopes. I spoke on, androgen gel for 2 consecutive x-rays during COVID, and here the T-Transport comes up this year with saying that it's not of any use.
No wonder Indian patients just pray to gods, and say, give me luck.
So
Because
now
I
Dr.
think
Damodar
that is
there.
highly right. That is very scientific. That is correct. That is going to correct the pituitary gland or pineal gland. So I think that is something which I think is going to work.
So
And
now
they
Dr. Damodar is there to clear so many of our doubts, because now even surgery has come under scrutiny. It has come in the line of fire. So Manisha, without wasting time, let's go and listen to what surgery is ethically correct for the endometriosis patient in 2023.
Damodar was traveling from Vellore. I think he managed to get a spot.
But he has responded
in.
to all my messages very sincerely. Thank you so much,
Hi,
Dr.
ma'am.
Damodar.
Good
Yeah.
evening, good evening.
Forward the
Am I
presentation.
audible?
Thank you so much, Anu Chawla ma'am, for the wonderful talk and updating us with the recent guidelines and articles. We'll move on to the next talk with the role of surgery, as Monica ma'am just said. What is the role of surgery in today's era in cases of endometriosis? And the talk will be delivered by respected Damodar Rao sir. And to chair the session, we have 2 chairpersons, Padmavati madam and Dr. Partha Sarthi Reddy. I think Padmavati madam is stuck in some emergency, so she is not able to join. And the next we have Dr. Partha Sarthi Reddy, sir. He is Superintendent of the Common Maternity Hospital, Tirupati, and Professor at Department of Obsgynaecology, SV Medical College, Tirupati, Andhra Pradesh. He is also Organizing Secretary of APCOG 2022 and President of Tirupati Obsgynaecology Society. As many publications to his credit, I welcome Partha Sarthi Reddy, sir. Over to you. Sir, are you there?
Hello.
Hello. Are you there, sir? Partha Sarthi Reddy, sir?
Did you talk to him, Dr. Manisha?
Yeah, I called him twice, ma'am.
Okay. So
Yeah. Third day I'm logged in.
So Dr. Damodar, I think
Sure. I'm ready. We can
I
start.
will introduce you. It's my pleasure to introduce Dr. Damodar, and then his talk can be summarized by chairperson when he joins. So it's my pleasure to introduce a great young man in front of all of us, a brilliant gynecologist who is also Dr. Asha Rao's son, and he is the director, Rao Hospital, Coimbatore. He has held the managing committee member post in the National IAG. He's still a member. He's the joint secretary of Tamil Nadu IAGE, co-convener of the Special Interest Group of Endoscopy of IFS 2021, treasurer of Coimbatore chapter of ISAR, organizing secretary of several conferences held in the South Zone IAGE, Yuva Foxy South Zone, Star Endogyne IAGE, and Pride IAGE. He has been bestowed many awards, and the best among them are the S. Ratnam Young Gynec Award of 2022 by AOFOG, and he is also a great academician, has received so many awards for best paper, and the Foxy Future Award, Yuva from the Yuva Foxy South Zone 2019, has written chapters in textbooks of infertility and endoscopy, and of course, he is the invited faculty at live surgical workshops. Welcome with all our hearts, Dr. Damodar, and we are eagerly waiting for your deliberation.
Thank you, ma'am. Thank you for that kind introduction. I hope, am I audible?
Yes, your voice is a little soft over there, but you could be a little louder, maybe.
Okay. Is this better? Slightly better? I don't know.
Yeah.
Okay. All right. I'm just going to share my screen. Is this seen?
Yeah, the screen is seen, but you have to put it on slideshow.
Slideshow. Okay. All right. So my talk is basically on surgery for endometriosis, and it's a very, very wide topic. I think since it's an ISAR topic, ISAR program, I'm going to be talking about more about fertility preservation techniques. And like Madam said, yes, surgery is also under the scanner, but everything else is also under the scanner. I think as long as you keep it simple, you will get decent results. I'm going to skip the definition and directly go into what a disease can present as a dilemma. It can present as infertility, pain, ovarian cysts, deep endometriosis, recurrence, and its sequel. Why is this a challenge? Because the laparoscopic technique, the amount of inflammation involved, the vascularity, the planning of the surgical intervention, and the extent of information provided to the patient, and the interdisciplinary coordination makes it a challenging intervention. So you have to really work up the patient very well, especially when you're talking about fertility. You have to look into things like AMH and tubal status if possible before surgery. You always have to counsel the patient about a lot of things about, what all is going to happen during surgery. You might have to disconnect her tubes, you might have to remove her tubes. If it is surgery for endometrioma, she might have a fall in ovarian reserve. All this you have to talk to the patient about. And you also have to go to the extent of even saying that she might require a colostomy. We have that in all our consent forms. So that's also something that's very important. I'll be talking about stage 1 and 2, and then about 3 and stage 4 endometriosis. What is the current teaching about stage 1 and 2 endometriosis? Usually, you don't go in for surgery for such a patient unless you're going in for a diagnostic laparoscopy for something else, or you're going in for a tubal cannulation, or you're going in for, if the patient has a lot of pain, then probably in such cases you might go in for surgery. And this is usually a chance finding, right? Stage 1 and 2 endometriosis, these are the small deposits that you see, but these small deposits are usually the tip of the iceberg, and they might go even deeper. So when it's usually what we usually do is you might see something like this, and then you will go ahead and just coagulate these lesions and then just release this adhesion, right? This was an older video of mine. This is what even I used to do back in the day. Just go ahead and coagulate that area. As long as you stay medial to the uterosacrals and above the uterosacrals, you don't really have to worry about the ureter in that area. And yes, a little bit of excision of the peritoneum over there was done too. This is something that we've started doing more of recent, like we have these endometriotic deposits over here. So when you see such lesions, nowadays we don't go and just coagulate those lesions. What we do is we remove the peritoneum in that area. Or I don't advocate a complete peritonectomy kind of procedure, which is an overkill. But in this patient, you see that almost all along the left uterosacral ligament, she had those peritoneal deposits. So in such cases, definitely, I think it's prudent that the peritoneum in that area is removed. Why? Because they say that definitely the pain scores are better. And another thing is the recurrence rates are a lot less. So there is a dictum that let her first surgery be her best surgery. So just coagulating these implants on the outside, you won't be going deep enough, right? Because you're always worried that the ureter might be over there, and you're just going to do some superficial coagulation and come out. But if you're able to dissect the ureter out in these areas and remove the peritoneum in that area, they say that the pain score is less, the chance of recurrence is also less. And there are a few papers that have also suggested that in cases that have failed IVF, if the patient has, this is just peritoneal implant, but if the patient has DI, you go and remove the DI, you go and do a complete removal of all these deposits, you remove the peritoneum, and people have conceived. I'm sure there are more papers required for this, but there are a lot of people doing it, and people are getting good results. Okay, so here you can see that even just over the rectum, there is a deposit there. So always, look deep inside, and then you will be able to identify all these areas. So if you're in doubt, put in a rectal probe, and then you'll be able to safely remove only these deposits. So this is what it looks like at the end. You can see that this whole peritoneum in that area is removed. And we don't really have to worry so much about adhesions because peritonization occurs within 24 hours, and you don't have to worry so much about it. What did Versilini et al. Say that if you do come across these lesions, do definitely do something about it. Ablation of lesions is better than no ablation at all, but nowadays the trend is to kind of resect these lesions out. Of course, ablation has to be done if you see something like this over the ovary, then definitely you can't sit and remove the ovarian cortex. You can just go and coagulate the disease over the ovary. So when it comes to endometriosis and spontaneous pregnancy, when it comes to stage 1 and 2 endometriosis, what does Escher say? I'm sure Dr. Anu Chawla has already spoken about this before. To perform operative laparoscopy, whether it's excision or ablation of the endometriosis, including adhesiolysis, to increase ongoing pregnancy rates. If you have CO2, then you can always do the CO2 vaporization and then go ahead. Ablation or excision is fine, but with excision being better because sometimes deep lesions may be revealed. CO2 can give good results. What about grade 3 endometriosis? This is, I think, a matter of debate whether to touch it or not at all nowadays. But this is also the favorite, pathology when it comes to endometriosis. When we see one, we all feel like, jumping on one, but it's not the correct word to use. But we should not. We should really refrain from, operating on endometriomas unless it's really, really indicated. Why? Because compared to dermoids or cystadenomas, the amount of normal ovarian tissue removed with an endometrioma is really high. The AMH rates really, really fall, especially if it is a bilateral endometrioma, right? So it falls about 24% after unilateral and by about 67% after bilateral surgery. There have been some studies that say that after about 12 months follow-up, there may be a slight improvement in AMH also. These are very few papers that suggest that, but we'll have to wait and see. The techniques mainly are, of course, your cystectomy. I started using a lot of vasopressin in my cystectomy, and incision and just ablation, and the 3-step technique, which is almost given up now. Cystectomy is sorry.
Dr. Rao, I think there's some internet issue.
Okay.
Yeah.
Yeah.
Now it's okay.
Is it better? Yes.
Yeah, it's fine now.
Okay. So basically, it's the gold standard way of doing cystectomy. Have a assistant come in and hold the ovary for you and kind of walk on the ovary, right? Hold the cyst wall, hold the cortex, and just peel it apart slowly one by one. Just don't hold it in the corners and yank it apart. So if you walk on the ovary and slowly remove this, many times you'll be able to get into a decent plane. There is nothing like the best, the exact correct plane is very, very difficult. You will always have loss of some amount of ovarian tissue. And when you reach the hilum, nowadays they say that it is all right to even leave a little, bit of cyst wall behind, because that is the area in which if you yank it out, it'll start bleeding, and then to control the bleeding, you're going to go and apply a lot of coagulation in that area, and which will further lead to a fallen AMH. So now they say when you reach this area, you can even leave a little bit of cyst wall and preserve the AMH. Because of that is exactly what I spoke about, vascular injury to the hilar region. It's called the Achilles heel of the ovarian cyst. So we have to be very, very careful. We've been using a lot of cystectomy also nowadays. There have been a lot of papers about the use of vasopressin for cystectomy. This is how this vasopressin being injected. And here you can see the cyst wall that's actually peeling off very nicely. And then you just have a few pinpoint areas which you can, pinpoint bleeders which you can go and coagulate later on. This is actually another nice video of vasopressin being used. Let's come to that part of the video. So, yeah, so here you can see that we always lift the ovary off the ovarian fossa to the anterior abdominal wall and release all the adhesions. See that the ovary is completely mobile. And once that is done, you can inject dilute vasopressin into what you think is the area between the ovarian cyst and the cortex, right? So in this particular video here, you can see that we've sort of got a good plane, and because of the vasopressin that is being pushed, you can see that the vasopressin itself is actually sort of doing the cystectomy for you, right? You can see that the cyst wall is completely bulging out of that area. And there's a little more being pushed out, and there you can see that the cyst wall itself is completely sort of separated from the ovarian cortex. And then all you have to do is hold the edges and separate it apart, and there you can beautifully see the cyst wall over there. So in such cases, when you do a cystectomy, you will see that there's hardly any bleeding. The fluid that is coming out is just the vasopressin that is actually coming out. And in the end, all you have to do is just go and do a bit of pinpoint coagulation. So I just went and did a little bit of peritoneal removal. And when I came back, see all that, it's a very, very nice area. And you can do a bit of pinpoint coagulation required. This is another technique, which is eversion and cystectomy. This I do when I think if it's a very big cyst or I'm not getting a good plane, then what I do is drain all the chocolate fluid out, and then we actually invert the cyst, right? To completely, here also I'm injecting vasopressin, and I have realized that it's in the center of the cyst that the adhesions are the least, and you actually get a very good plane over there. And you just, after inverting it, you make a nick in the center, and then you continue this incision from one end to the other in the middle. So basically you get two leaves, you get two parts, and then you can go ahead and do a cystectomy on either side. See, it is always in the periphery of the cyst that the adhesions are maximum. So if you're not able to get a plane on the periphery, you can go to the center and then come to the sides, and you can see that you're getting a very nice plane over there. Again, yes, there has been a lot of discussion about size. There is no real size nowadays that we talk about, especially when it comes to IVF. I just come to that in a point in a bit. So this is about vasopressin injection and how it helps reducing the fall in AMH. There are a lot of papers on this particular topic. If vasopressin does not work and if you're in the wrong plane and there's some amount of oozing, then you can definitely go ahead and take a bite to control the oozing. I would rather do that than apply a lot of, diatherm. Advantage of suturing over bipolar, they say that suturing has the advantage of avoiding thermal spread and potential tissue damage that may occur when hemostatic measures achieved with electrosurgery. Hemostatic sealants, I don't have much experience, but they haven't given great results either. And there is a small chance of small bowel obstruction. Three-step procedure, this is supposed to be the gold standard back in the day, but it's almost given up. You'll have to have your patient to come for surgery, twice. And no patient is willing to do that now. What about cystectomy versus ablation? So Horace Roman, he is a man who's doing a lot of work on, surgery in endometriosis in France. And I've also trained with him. And he uses a lot of plasma energy ablation. It's a kind of energy which does not penetrate too deep. And he speaks about using that instead of doing a cystectomy. I have a video for that. I'll talk to you about that. So when it comes to ovarian endometrioma, excision of the endometrioma capsule instead of drainage and electrocoagulation on the endometrioma wall for people who want spontaneous pregnancy. right? Decision to proceed with surgery should be considered carefully in women who's had a previous ovarian surgery. Always, if she's had a previous surgery, and if you're again going to operate on the same ovary, do her AMH, prior. And if you're going to operate on her, I mean, it's not going to be an easy surgery. Cystectomy is not going to be easy. You really have to think 1,000 times before you touch this ovary. Stage 3 and 4 endometriosis, you can consider operative laparoscopy instead of expectant management. This is all for spontaneous pregnancy when you're thinking of when the AMH is decent. Again, we're talking about size. Before, the cutoff was about 3 centimeters, but there is no such evidence that cystectomy prior to treatment before ART improves pregnancy rates. If she has no pain and if you think there is no difficulty in accessing the follicles, then you can directly go for ART. What about hormonal treatment? Before surgery, there is no role for hormonal treatment before surgery at all. Even post-surgery also, there is no real treatment. Usually, or if it's a spontaneous pregnancy or for IUI and things like that, you have to look into something called the endometriosis fertility index. And the best time to become pregnant is soon after surgery. The next cycle itself, they can start trying. Coming to newer interventions, this is what I was talking about. This is not my video, it's the video of Horace Roman. So what he does is basically he takes out all the chocolate cysts and then he everts it and then he uses plasma energy on it. He says it is almost like laser. It's a kind of bipolar kind of technology. It's a different energy source altogether. And the depth of penetration is not as much. So there is not much damage to the ovary itself. And the recurrence rates and pregnancy rates are also very promising with this method. So basically, able to kind of ablate the whole cyst wall using this plasma energy. Something else which has also been tried is ethanol sclerotherapy, which also they've been trying with good results. Basically, even if it is a big ovary, you just have to make an incision, drain out all the chocolate fluid, and once the chocolate fluid is drained out, you use 90% ethanol, right? And you inject it into the ovarian cyst using Foley's so that there is no spillage of the ethanol. And once that is done, you just keep it there for about 5 minutes, right? So here you can see the Foley's is being introduced and then the ethanol is also being pushed in and then it's kept over there for about 5 to 7 minutes. You just wait and it's supposed to cause damage to the cyst wall. They do say that the recurrence rates are less and pregnancy rates are also quite decent. And the fall in AMH is also a lot less. So this is also something promising for the future. Next, I think I'll just go a bit into DIE, where people are doing this butterfly peritonic. How much time do I have?
You can finish your talk, Dr. Rao, no problem. You have maybe 5 minutes.
Okay. So this is basically done for a reserved set of patients in whom, they have deep infiltrating endometriosis and they've already had an IVF. I know that, I mean, the dictum now is even if they have stage 3 or 4 endometriosis, if there is DIE also, you can directly go in for an IVF unless she complains of severe pain. Okay. This is for a set of patients in whom they've failed IVFs, right? They've had stage 4 endometriosis, they've already gone through 1 or 2 cycles of IVF, and they're still not conceiving. In these set of patients, you can think of going ahead and doing a complete excision of all the endometriosis that is there. And this basically has a mnemonic called SoSure resection. Basically, they talk about sigmoid mobilization, and then you do ureterolysis on either side. Then you do the ovarian mobilization, and then you suspend the ovaries. So these are all very, very standardized steps now. So if you do these steps, you're able to get into the right spaces, and then you're able to remove most of the lesions. So once you've done a ureterolysis on either side and you have mobilized the ovaries also on either side, you can pinch the uterus or you can use a uterine manipulator, whatever you're comfortable with. Sorry. That is suspension of the ovary being done, and then you do a ureterolysis. These are also the same steps one does if you want to do a hysterectomy in the case of stage 4 endometriosis, right? Basically, you open up all the spaces. And now the most important space is the pararectal space. Before we would attack this space right in the center over there, but now, you know, we know that there is this pararectal space where you can work parallel to the rectum on each side and then reach the lesion, which is between the cervix and the rectum, right? So that's what we all do nowadays. So that's the pararectal space being opened. So either you can cut through the lesion, or you can leave the lesion on the bowel. Some people cut through the lesion and leave a little bit of lesion on the bowel. Some people cut above the bowel and leave the lesion on the uterus. So however you do it, you have to remove the nodule completely. That's the pararectal space being entered, and that is the rectovaginal space being entered. That is the right pararectal space. It's also called the space of Okabayashi. This is where the nerves also run the S2, 3, 4. And finally is the resection of the butterfly area is what it is called, because this is the affected area. This is the left uterosacral. You go and then finally remove the implants on the uterus. So from the left uterosacral, you come to the uterus and then you go to the right uterosacral. Right at the end, you come out removing what is something like a butterfly shape, right? That's why it is called the butterfly shape excision. Okay, so this whole thing looks like the wings of a butterfly. So doing this, some people have got good results after failed IVF. So this is for a very, very select set of patients. I'm not saying that it should be done for all patients, right? So I'd like to conclude by saying defer from surgery as much as possible. But if she has to be operated, let the first surgery be hopefully be her only surgery and the best surgery. Nowadays, great optics, 3D, 4K, and we have a lot of good surgeons and teachers, especially in India. Techniques have been standardized. I think we too have to evolve along with that. Thank you.
Thank you for a great talk. Did Dr. Partha Reddy join? Dr. Manisha?
No, ma'am, doesn't look like.
Okay, okay. So we are having some coordination issues, but Dr. Damodar, you have given a final, you're the last batsman who has given us the World Cup. So we really enjoyed. And just a quick question: how does actually vasopressin? It's because we use vasopressin in myomectomies, lap myomectomies, basically, to ease that, give us that window period when bleeding would be less. Now it has come into disrepute also because of the complications involved. But is the dose in endometriotic cysts different? Number one. Number two, what precautions to be used so that you don't push drug into vascular spaces? And number three, how does it help? Means you are a proponent of teasing out the cyst wall or ablating?
No, definitely no. Between ablating and removing the cyst wall, depends on her AMH. If her AMH is good, then definitely cystectomy is what she should definitely go for. And while doing a cystectomy, when it comes to vasopressin in particular, vasopressin is number one, the same dilution. It's a 10% solution, the same one we used in myomectomy, but the amount is very, very little. In myomectomy, you use 100 ml, 200 ml. Here we just use about 5 to 10 ml. And you inject it into an area between the cortex and the cyst wall, and at the center of the cyst, and it's highly, it's not vascular at all, unless you go to the hilum of the ovary. That is where the whole vascularity is. So like any other place where you're injecting vasopressin, you first aspirate, And if you see if there's any blood coming, which will almost never happen in a cystectomy for an ovarian endometrioma, and what it does is it also helps in giving you a nice plane. And the amount of bleeding is also less. Sometimes while doing a cystectomy, you see a lot of blood coming, and then you're not able to see where exactly you are. But here I've seen that it gives you a good plane, and the amount of bleeding also, the end of procedure is quite less.
Does this endometriotic cyst or the OMA have a capsule? Because literature says it doesn't have a capsule as such.
Yeah.
Basically, when you're teasing out that cyst wall, whatever be the precautions you're taking, you're bound to take out a strip of the cortex as well.
100%. That I've already mentioned. You could be the best surgeon in the world, but you are going to cause a fall in AMH. I'm not refuting that statement at all. But it definitely helps in reducing the fall in AMH compared to not using vasopressin. And there have been enough studies to support this.
So what is that particular endometrioma which you will definitely remove before your oocyte retrieval, and which is the endometrioma you would rather leave behind?
See, if it is endometrioma which is large, and if you think it is coming in the way of your pickup, then definitely that is the one which you should tackle. Or if she has a lot of pain, she has unbearable pain, then that is also an indication for surgery. But if they're not too big and you think that you can do your pickup without going through the endometriotic cyst, then you can definitely avoid surgery for these patients.
And a quick question for Asha ma'am. I think she's still there. I'm troubling her with lots of questions. So ma'am, if you inadvertently puncture your endometrioma during oocyte retrieval, suppose it's a 2.5 centimeter endometrioma and you puncture it, would you land up with any complication, or you can just give a course of antibiotics, some oral antibiotic to reassure the patient and plan your transfer?
Sharing, if I will share.
Asha ma'am, I think. Damodar, you can answer.
You can just.
I made you co-host.
Dr. Damodar?
Yeah, I think I got into another webinar, so you should excuse me for that.
No, it's okay, ma'am.
It was a wonderful program, and wish you all the best, Monica.
Yeah. So Dr. Damodar, would you like to? Yeah.
You can reassure the patient, you can give her antibiotics, and then you can tell her. But then we have to be watchful also, right? For any signs and symptoms of any kind of abscess forming. Otherwise, you don't have to worry about it too much. You can give a good wash also and come out.
Okay. Thank you so much.
Thank you, ma'am.
Thank you for the wonderful talk. And I think now we are at the end of all the talks. And Dr. Manisha and Dr. Purnima, we can move on to our panel discussion, because all our panelists must be waiting.
Yes, ma'am. Panel discussion slide, Dr. Vishal.
Dr. Vishal, can we start the slide?
Panel discussion.
Yes, ma'am.
Yeah.
Just sharing.
So Dr. Purnima, no need to introduce myself and Manisha. You can just invite the panelists. You can just tell us who the moderators are.
Okay, ma'am. Yes, ma'am. So the topic for today panel discussion is endometriosis, perplexing clinical cases and evidence-based management. And our moderator are Dr. Monica Singh ma'am and Dr. Manisha Jain ma'am. And our panelists are Dr. A. Sridevi. Ma'am is Associate Professor in Department of OBGY, GGH, GMC Ongole. And she is an alumni of Kurnool Medical College and SBMC Tirupati. And she has been trained in Harvard T2T and got the Best Doctor Award 2 times from District Collector. We welcome you, ma'am. Dr. Sridevi, ma'am. Thank you, ma'am. And our next panelist is Dr. Apurva Pallam Reddy, ma'am. Ma'am has done training in reproductive medicine, infertility training, diploma in gynae endoscopy, and also in ultrasound. She is editor in decision making in infertility and also consultant reproductive medicine and cosmetic gynecology at Phoenix Specialty Clinic, Bangalore. Welcome you, ma'am. Thank you for joining us. Next panelist is Dr. Baby Shalini. Ma'am is consultant and managing director at Shrestha Hospital, and she is also secretary at Chittoor OBGY Society. She has a certificate course in contraception and GDM, and having area of interest in creating a positive childbirth experience, PCOS and minimal access surgery, and has done various paper publications. We welcome you, ma'am. Thank you for joining us. Our next panelist is Dr. Chandana Veera Machanini, ma'am. Ma'am has done ultrasound recognized training by AOFOG at Mediscan Chennai, and also done training in advanced laparoscopy and ART. She has served as VOGS treasurer, organizing committee member for UA Foxy South Zone 2018, and also secretary AP chapter of SR from inception till 2020. She is secretary of VOGS 2022 to 2023. We welcome you, ma'am, on this platform. Thank you for joining us. Our next panelist is Dr. P. Siresha Rani, ma'am. Ma'am is founder and managing director of Medsi Hospital. She is founder and managing director of Vizag IVF Center and Lancet Laparoscopy Center, Vice President AP SAR Chapter, Special NT ART State Board, Joint Organizing Secretary Andhra Medical College Century Celebration, Secretary AP Nursing Homes and Hospital Association, Secretary of OGS Vishakhapatnam, Secretary of IMA Women's Wing Vishakhapatnam, Joint Organizing Secretary for UO Foxy South Zone, and ma'am has so many publications in various journals and has been received Most Preferred IVF Doctor in AP Award. We welcome you, ma'am, on this platform. Thank you for joining us. Our next panelist is Dr. Sujayasree Sangeeta, ma'am. Ma'am is a consultant obstetrician and laparoscopy surgeon at Seshadri Hospital, Palakol, Seshadri Hospital, Malikipuram. Ma'am is founder secretary Bhimavaram Obstetric and Gynec Society and secretary IMA Palakol. She has received Shan as Ratnam Young Gynec Award and also Foxy Dhira Award. She has done various paper presentation and has been organizing secretary of GUSA 16 and 18. She has done various community work as well. We welcome you, ma'am. Thank you for joining us. Our next panelist is Dr. Uma Shankar, sir. Sir is clinical head and infertility specialist, Ahalya Nursing Home and Ahalya Hospital, Guntur, Sri Ahalya Hospital, Vijayawada, Andhra Pradesh. Also secretary in GOGS, joint secretary in APOX, executive member in AP SAR, organizing secretary with 5th APCOG, and also won Jagdeshwari Mishra National Award for Best Poster Presentation. So many awards into Sir credit. We welcome you, sir, on this platform. Thank you for joining us. Our next panelist is Dr. V. Radha Lakshmi. Ma'am is presently working as Professor Obs Gynae Department at Santira Medical College, Nandyal. Also has worked in KMC Kurnool and GMC Anantapur. Ma'am has received gold medals in UG and Best Doctor Award in 2017 in Kurnool. Ma'am has published various papers, and also she has been General Secretary of Foxy, Kurnool and Nandyal District, Zonal CME Coordinator of Zone 6 OBGY, Vice President of APCOGS. We welcome you, ma'am. Thank you for joining us today. So these are the panelists. And now I hand over the session to our moderators. Thank you, ma'am.
Thank you, Dr. Purnima. And welcome, a warm welcome from Bhopal Obs Gynae Society and ISAR Perfection Series to all our esteemed panelists. And thank you for taking out time from your busy practices to join today. And I think a lot of our panel questions have already been clarified in the talks, but we'll just be giving you some brain tickling questions, which I know you must be all perfect at it. So these questions are not directed towards any panelist. It's an open discussion. And Manisha, you can start sharing the screen because we have a lot of slides to cover, around 100 slides. So we'll just go fast, and all the inputs are most welcome. Because as we all discuss, endometriosis is a problem where there are evidence-based recommendations, there are guidelines, as well as there are some good practice points which will come from all of you.
So very good afternoon and good evening to all the panelists. We look forward. Despite we know that since afternoon we have been discussing endometriosis and how enigmatic disease this is. Till now, despite the lot of evidence available, we still are perplexed as how to manage this disease. So the objective of today's panel is to bring forth evidence-based management guidelines. And when we look for the Cochrane study, we see that continuously for the past, since 1949, this disease has drawn interest of all clinicians and researchers. And every day, the number of researchers is increasing day by day. Although various etiopathic theories have been implicated in its etiology.
So let us start the first question, Manisha, from this. Let's stick to the slide.
I'd like to ask all the panelists how prevalent is endometriosis in infertile women?
Yeah, and in your practice also.
Yeah.
So anybody can take this question. What is the prevalence of endometriosis?
Prevalence hello ma'am, this is Dr. Jayashree. So the prevalence when it comes to general population is around 10%.
I request everyone to put themselves on mute except the speaker, and I would request all panelists to please switch on their cameras.
Yeah, and the prevalence increases when it comes to the infertile population, almost up to 25 to 50%.
Yeah. The overall prevalence is about 5 to 10% in the general women of reproductive age group. But when you see a cohort of infertile women, the prevalence could be as much as 25 to 50%. And Dr. Sujeshri, tell me, what is the average latency period before which you diagnose an endometriosis patient? Do you waste some time just suspecting and diagnosing before you start treatment?
Actually, there is always a delay because most of the time the clinical examination or our diagnostic modalities do not pick up endometriosis, especially when it is superficial. So there is usually a time lag between, making a diagnosis between when the patient arrives and then we come to a conclusive diagnosis.
So do you think there is a difference in practice and difference in the latency period of diagnosis with the advent of TVS? Once transvaginal sonography has come into all our chambers, into our offices.
After TVS has come, rate has increased, but it depends upon the type of endometriosis. If it's very superficial endometriosis like peritoneal deposit, you're not likely to pick it up. But if it is a blatant ovarian endometrioma or you have deep endometriosis, rectovaginal nodule, you're more likely to pick it up on TVS.
Yeah. So can now can we go to some other panelists? Maybe Dr. Chandana or Dr. Radhalakshmi or Shalini. Can you tell us what we all studied the etiopathogenetic theories for endometriosis? Retrograde menstruation, hematogenous spread, lymphovascular spread. Are there some other theories which are very much in vogue nowadays and are being extensively researched? Can you speak a few lines about that?
I think it is most commonly implantation theory by Sampson, and more commonly seen when there is obstructive Mullerian anomalies. So in cases when you remove the obstruction or remove the horn, the chances of recovery of the endometriosis is very good. And infertility treatment also very much useful in an obstructive type of endometriosis, I think.
So is there somebody who can add to this? Does it always have to be an obstruction? Then how does it explain?
It cannot be always obstructive.
Yeah.
It will have good prognosis when there is obstruction. If you remove the obstruction or remove that horn.
In fact, the distant spread and the the sites of endometriosis like lungs, pleura and all, they suggest that sometimes it is just another method of spread. Maybe, these endometrium emboli spreading or small fenestrations in the diaphragm through which these emboli spread. So it is basically now genetic theory is also coming. They have studied, twin sisters. One with endometriosis and the second sister is also genetically predisposed and the mother also had this. Then there is something called, immunological theory. Maybe the patient of endometriosis has got some immunological factors in the body which lead to more inflammation when retrograde menstruation occurs in her. So this is all. So basically that is why the latest treatment is coming to something which is dealing with antioxidants, anti-inflammatory, stem cells. All these treatments will come once we understand this. Okay, Manisha, next, please go to the next.
So we all agree that there is a reduction in fecundity in women of endometriosis, and it is seen that infertile women are 6 to 8 times more likely to have endometriosis than the fertile women. and this reduction to the tune of 0.02 to 0.1%
compared to the common.
So I'd like to ask the question to the panel, dear panelist, is how the endometriosis causes subfertility in our women.
It could basically be due to
so-
some disturbed pelvic pathology. It could be a poor oocyte or an embryo quality, and endocrine disturbance which can happen. And as ma'am has rightly mentioned, an altered cell-mediated immunity. And of course, an impaired implantation and endometrial receptivity, wherein there is progesterone resistance and estrogen dominance. And of course, the male partner should never be neglected, wherein he can have a decreased sperm quality and function.
Yeah, very rightly said, Chandana ma'am.
The oocyte quality also is reduced markedly. So the oocyte and embryo quality also affects the outcome.
Yeah, so it has more than one point of affection. It almost affects almost all aspects of the fertilization. So
There was one school of thought which said that in these women, studies were done that if you take the oocytes from a donor, a non-endometriosis donor, then these with normal oocytes, these women and their uteri demonstrate a normal endometrial receptivity and almost a similar pregnancy rate as a non-endometriosis woman. But at the same time, nowadays the studies say that endometriosis and the immunology and the inflammatory mediators are affecting all the tissues of the body, including the endometrium. So the studies done in the recent past and the present studies, they are a little conflicting in nature.
So we all agree with all the following points.
Yeah. We've
So-
already discussed about the progesterone resistant and the estrogen dominance in such disease. That is why we are marketing companies and pharma companies are coming up with these combinations of estrogen plus Dynogest. But actually, it's a something which should not be FDA approved, because why should you add estrogen in a combo where your main aim is not to cause the estrogen dominance? Yeah. So all that discussion was actually coming to this also only. So, can the panelists please tell us what modalities do you use in the diagnosis of a patient of endometriosis whom you suspect to be endometriosis?
Madam, women having the chronic
usually
pelvic pain.
come to us.
Good evening, ma'am.
Yeah, what we were trying to say is based on you actually them based on history taking when they have symptoms of either cyclic, non-cyclic, dyspareunia. They also have some amount of history of infertility. All this will make you suspicious that they could have endometriosis. So the first thing you would be doing is a clinical examination. If she's not an adolescent, you can always do a bimanual palpation around the menstruals so that you can identify tenderness, some amount of fixity, and maybe you can palpate adnexal masses if there's an ovarian endometrioma. If even though it is negative, you should always follow it up with a transvaginal ultrasound, which will give us a clearer picture of whether there is anything indicating endometriosis. In spite of all this, if there is, if it's a young patient who's not very keen on her fertility, you can always continue with empirical treatment and see if there's improvement in dysmenorrhea and her symptoms, which will indirectly indicate that she could be suffering from endometriosis. Even if empirical treatment fails, then I usually follow it with diagnostic laparoscopy. And during the time of surgery, if you see endometrial nodules or deposits, convert it to an operative laparoscopy and treat them in the same sitting, which would be beneficial for the patient. The role of MRI biochemical markers are not validated. We don't have enough studies to support the same.
Any comment on diagnostic laparoscopy, as Madam said, from any other panelist?
So normally, most of the adenomyosis cases, they can be diagnosed by ultrasound transabdominal followed by TVS nowadays. When the patient
diagnostic laparoscopy as we used to do earlier.
And the patient is not responding to treatment only or not conceiving with our treatment, especially with the ovulation induction and IUA, we prefer to do laparoscopy to know whether the tubo-ovarian relationship or any endometriosis in the pelvis. As such, directly we don't pose the patient
You
for.
can always do an excision biopsy also, so you can do a
Yeah,
histopathological
it's always an
continuation.
operative
The
laparoscopy,
same.
just the diagnostic one.
So the message is that when you put a scope, it should always be with the intention to operate. The
Yeah.
role of diagnostic laparoscopy is not there, and Dr. Radha Lakshmi has been very precise that it is only recommended if your imaging is negative, your clinical examination is negative, the symptoms are still there. So you want to confirm and you want to rule out those powder burn lesions and the superficial endometriosis, probably take a tissue for histopathology, but still a negative histopathology is not an indication that endometriosis is not there.
Any
We
role of biomarkers, as so much of research is going on potential biomarkers in diagnosis?
There's no role.
Studies support that the biomarkers in any tissue fluid is beneficial.
So yeah, the panelist has given clear-cut messages to our audience that there's we have to keep a high suspicion of diagnostic endometriosis, even though if the ultrasound is negative, it does not rule out endometriosis. And in women whom there's a ultrasound imaging is negative, they may be offered laparoscopy with the intention of giving a therapeutic laparoscopy, not just diagnosis. And biomarkers and histology does not rule out disease or have no role in diagnosis of endometriosis.
Moreover, this biomarkers study is costly and not affordable for all the patients.
Yes, madam. And apart from that, biomarkers at present in endometriosis is only for a research setting. And
Yeah.
research setting for taking out, maybe in the next decade or 5 years, they come out with some sort of immunomodulatory treatment for endometriosis. They can tell to the whole world. But if some random lab person comes to you that this is a biomarker for endometriosis, you should not, give in to the temptation and avoid wasting that much money and time for the patient. Rather proceed with the guidelines. And the guidelines have become very simple nowadays, very clear. Okay, proceed, Manisha.
Yes, so what are different clinical phenotypes we encounter in our practice and what different clinical classification systems used? Madam, what is your experience?
What are the classification systems you use? What are the phenotypes you perceive?
There could be a peritoneal,
You have 3 phenotypes.
an ovarian, or a deep infiltrating endometriosis.
Any particular?
The peritoneal one and the superficial deposits. Yeah.
Who's speaking?
When it comes to the staging, Dr. Chandana, are you answering? Will you be answering the question?
Yeah. When it comes to staging, the old classification was an ASRM classification wherein stage 1 is minimal, mild, stage 2 is mild, and stage 3 is moderate with a scoring of 15 to 40, and greater than 40 points is considered severe endometriosis. But ASRM classification of late is not followed widely because it doesn't have any role in management of the patients. So recently, it is the EFI scoring system which has a better prediction for the patient fertility outcome. You can score the patient in such a way from 0 to 10, wherein a patient having a score 0 will have a poor outcome.
So we have the classification system, NCN classification,
Yeah.
ASRM classification, and EFI.
Yes.
Yeah. So she can EFI. She can talk. Chandana, you can talk about EFI. No problem. Then we'll come to the cases. Yeah.
EFI is for basically managing your patient from the infertility side, wherein the chronic factors, including the time of surgery and the adnexal function, are also included in this classification. And the age of the patient is less than 35 from 30. In between 36 and 39, and if she is greater than 40, and whether she is married for less than 3 years or more than 3 years, and whether she is having a prior pregnancy or not, all these are considered in giving a scoring to your patient. So we can counsel the patient in such a way that if she is having a score nearing 0 or 0, her pregnancy rates are going to be low, and if it is 8 to 9 or 10 scoring, then she'll have a better ART prognosis with ART.
EFI scoring is actually not the higher the score, the better is the prognosis. Yeah, I would just request everyone.
Ma'am, but EFI is not to stage the disease.
Sorry? Your voice
Ma'am,
is
EFI is not.
audible. Dr. Sujayashree, you are.
Am I audible now, ma'am?
Your voice is breaking too much. So, I mean, we cannot
Ma'am, am I audible
understand
now?
what you're saying.
Ma'am,
You're
is it better
audible
now?
a little bit, but better. Yeah. Tell me.
Ma'am, actually, EFI is not to stage the disease. That is a scoring system to decide whether ART will benefit the patient post-surgery.
Yes.
So staging is only with your RASRM and your Indian classification. There are only two things staging, ma'am.
Yes. So EFI is basically the sum total of, all the staging and your clinical assessment. And nowadays EFI can be done without invasive procedure. You can assess EFI even with non-invasive techniques and come to a conclusion, as rightly remarked by Chandana also and Sujayashree also, that basically you want to know what is the prognostication of the patient and chances of the patient conceiving by ART. Okay, coming to the cases, Dr. Manisha, please take the first case.
So take the first case. Is 23-year female, and Mrs. XYZ, has been married for 2 years. She consults us for primary infertility. On questioning, she has dyspareunia and dysmenorrhea. Her cycles are regular, lasting for 3 days every 30 days. Semen analysis also grossly normal. However, TVS detects no abnormality. She underwent laparoscopy somewhere outside and shows mild peritoneal defects and lesions less than 1 centimeter. However, the tubes had a bilateral spill of the dye. So, what is the probable cause of infertility in this case? What is the role of various diagnostic modalities we have already discussed, but we can just brush upon it? Role of diagnostic laparoscopy, role of biopsy, and how would you like to proceed?
I think we have dealt with all of this. You can proceed. Yeah.
So we
Just
can,
the guidelines. So can somebody revise these guidelines for us? Dr. Baby Shalini or Dr. Chandana, Dr. Radhalakshmi, any of you? Yeah, please. Just give us a one-liner of all the guidelines.
Clinical. So whenever we do clinical exam, before clinical examination, we have to ask the complete history of the patient. And clinical examination, especially perspiculum examination, to know whether there is any deep nodules on PR should be done. And further diagnostic steps are mostly the transabdominal sonography followed by transvaginal sonography, especially when there is the involvement of rectovaginous septum. And then laparoscopy need not be done for each and every cases. And if the patient is not responding to treatment, or if the patient his age is more like 35 years, we can go directly for 35 diagnostic laparoscopy to know whether the tubes are patent or not. And at the same time, we can do operative procedure also for the removal of these endometriotic spots in the peritoneum. And also,
I would like to interrupt here,
remove the adhesions also.
Dr. Radha, I would like to interrupt. Age has got nothing to do with your decision for operative laparoscopy. Operative laparoscopy is basically done where you want to confirm the diagnosis, where findings of imaging and clinical examination have been negative, but the patient has got persistent symptoms, she's suffering from the symptoms, or you want to do some alongside any operative procedure. So age has nothing to do with the decision for laparoscopy over here. And one more thing, we always, because of the easy availability of the transvaginal probe, all of us forego the clinical examination. So a PV examination, which we used to do in our post-graduation days, and putting a speculum there to look for that endometriotic nodule, it'll never fail to help you. We should always try to incorporate that into our practice, especially if the clinical features of that patient who walks into your chamber are suspicious. Okay.
Ma'am, but in this case scenario, everything has been done. She's also undergone a diagnostic laparoscopy with ablation of the deposit.
Positive findings. Yeah. She had powder-borne lesions.
So, we have done it up to the diagnostic laparoscopy. There is no role of histopathology because they've already done the lab and they haven't sent anything for the histopath. So right now, what we have to follow it up with is the treatment protocol. Because it's a stage 1 or 2 ASRM, she'll benefit with controlled ovarian stimulation with IUI.
We are coming to that. Manisha, just go with the slide. let's hurry up now. Yeah.
Okay, so this is already we discussed. We see that the ultrasound, though, is mostly available with all of us, but it has mostly sensitive in ovarian and deep endometriosis, but in superficial disease does not seem to be superior to diagnostic laparoscopy.
Achha, any
So-
role of MRI? Anybody among you is doing MRI for your patients?
No.
Ma'am, I am doing MRI in only indicated cases, ma'am, but never for endometriosis because I think mostly a clinical history, ultrasound, and a clinical examination should be sufficient to arrive at a diagnosis with empirical treatment.
So in Western countries, MRI is still, used more liberally than in developing countries like ours, and it just gives you a wider outlook. The probe can only tell you whatever the probe sees, wherever the ultrasound waves are going. But MRI will give you, first of all, very clearly demarcated indication of the lesions and also a wider view. These were the only two indications, two advantages of MRI which are found on reading. But as rightly remarked by Dr. Sujayashree, we are not doing MRI routinely at all. Okay.
So coming to the treatment modalities,
excuse me,
is there a role of expected management or what is the role of medical and surgical management in these ones?
No, the medical and surgical treatment has also already been dealt with.
Yeah.
We need to go through the guidelines. Are hormonal or medical therapies effective for the treatment of endometriosis associated infertility? And is surgery effective to increase the chance of a natural pregnancy? This, please answer with relevance to case number 1.
Ma'am, considering she's an infertile patient seeking pregnancy, there is no role of hormone therapy because that brings about ovarian suppression, which negates what we want. It will impair ovulation. So here there is no role of pre-treatment with any hormonal therapy. Coming to the second question, which is a question about what's the role of surgery. If you're looking at an infertile patient, she's already undergone laparoscopy with reference to this case. So here there is no role for surgical management.
Yes, there's no role of hormonal suppression. There's no role of this thing. And the best line of treatment, of course, would be controlled ovarian stimulation.
With IUI.
Because as we will proceed further with the cases, you'll know doing natural cycle IUI or oral ovulagens will not work as much as using gonadotropins. Because these are the follicles which are, basically they are late to grow. They are difficult to grow, this cohort in endometriosis women because of the surrounding inflammation. So you always need that extra kick of gonadotropins to get good results. And you do get good results with patent tubes.
So next recommendations are that infertile women with endometriosis should not prescribe ovarian suppression, as very well mentioned by our panelists. Operative laparoscopy, it is not diagnostic, but operative laparoscopy could be offered as a treatment option for women with stage 1 to endometriosis, and as it improves the rate of ongoing pregnancy rates. Similar other recommendations.
Excuse me, madam. 1 minute. One question. Some advice of fallopian tube clipping before doing ovulation induction and IUI. What is your opinion about that?
Fallopian tube clipping before IUI?
IUI tube has been patent.
No.
No. Sorry. In
there's evidence of hydrosalpinx.
IVF. Sorry.
Hydrosalpinx in IVF.
No. There is no role of doing any sort of tubal clipping or occlusion in endometriosis. You are looking for patent tube. In fact, even with a single patent tube, you can proceed with IUI. In such patients, I have got results with IUI even in stage 3, stage 4. We had given up. Patent tubes were there and she conceived, that patient. Not 1, 2, but maybe 2, 3, 4 patients conceived like this. So I think you were getting confused with hydrosalpinx. So any role of anti-inflammatory drugs, anti-estrogens, aromatase inhibitors in improving fertility? Any of you can take this question?
Ma'am, anti-inflammatory, can I answer? Does someone want to take it? Can I answer? Ma'am, anti-inflammatory mediators are nothing but your prostaglandin COX-1, COX-2 inhibitors. And your COX enzyme is important in the pathway for ovulation. So any kind of anti-inflammatory drugs will inhibit the same and hamper ovulation. So they're not to be advised in individuals seeking fertility. they have no role in treating endometriosis for infertile patients.
And the role of aromatase inhibitors?
Aromatase inhibitors as an ovulogen can be considered, but not for its other uses like its anti-inflammatory
The
purpose.
level of estrogens, yes. It is not to be used as an to lower the estrogen level, but as a pure oral ovulogen, letrozole has got a role. Okay, so we all agree with this.
Yeah.
Manisha can summarize.
Yeah, the recommendations are that patients should not prescribe anti-inflammatory like pentoxifylline and other anti-inflammatory drugs or letrozole outside ovulation induction to improve the natural pregnancy rates.
Okay, let's go to the next.
Move on to the next question. What is the role of hormonal or medical therapies as an adjunct to surgical therapy?
I think we can skip this, Manisha. We have done this so many times. Yeah.
Okay.
Yeah. Another thing is post-operative hormone suppression. You have operated upon this patient, you have done an operative laparoscopy, you have burned ablated some powder burn lesions, okay? You have even taken a tissue for biopsy and say it is positive also. Now this woman wants IVF after maybe Diwali. She wants a gap of 2 months. Would you use post-operative hormone suppression, any of you?
Only if she's having symptomatic pain or we operated her for her symptoms, then you can put her on on oral the hormone suppression because it will negate the pain. But if she has no such, you don't have to put her on suppression.
And I think we all agree that after surgery, once you deal with these patients with, operative surgery and a good surgery, then most of them are pain-free. I think, psychologically also they are better. And after good surgery, they are pain-free. So actually it's not recommended. So Manisha, can you summarize, please?
Yes, so the FOXY recommendations are that clinicians should not prescribe adjunctive hormonal therapy before surgery to improve spontaneous pregnancy rate, and also should not prescribe adjunctive hormone therapy after surgery to improve spontaneous pregnancy rate, except in women who have pain or symptoms or who are delaying pregnancy.
And this is evidence level A.
Yeah. So, what is the role of expectant management IUI when compared to expectant management IUI alone or ovulation induction with IUI? What all you prefer in your practice?
Ma'am, anyone else have? Ma'am, actually here in case of endometriosis, preferably controlled ovarian stimulation with IUI is preferred.
So
Neither
just tell us in this particular case, now she has come to you after laparoscopy, after being diagnosed and everything. She is around 29, 30. She's never conceived in the past. What is your typical protocol, your gonadotropin of choice, dosage regime for your first 3 IUI cycles?
Ma'am, in what I do in my practice is I start them with oral ovulogens so that the load of gonadotropin is decreased, and then I call them back for a scan on day 7. Based on the follicle growth, I taper the dose of my gonadotropins. Preferably in patients with endometriosis or PCOS, I prefer using FSH, pure recombinant FSH, follow up the follicle growth until it reaches its size, and then trigger it with a HCG for rupture, and then do an IUI subsequently 36 hours after my trigger, if it's a single IUI.
Anybody doing using HMG instead of REC FSH? Dr. Chandana, Dr. Shalini? Anybody who is a proponent for using HMG instead of FSH? Do you believe that FSH is better, or do guidelines or do recommendations say otherwise?
We often see patients of PCOS or endometriosis not responding to normal FSH, ma'am, because these are the cases of FSH polymorphism. Usually it is like, suppose we would have done, for all such cases of endometriosis, we would have done an AMH baseline and also an FSH LH. Suppose the FSH LH ratios are normal, we can always go ahead with starting off with HMG rather than direct. And no need of going to a recombinant FSH directly. We can start with
yes. My message is to all the audience that, okay, my preferred drug, Dr. Sujaya, is also REC FSH because of the availability of nowadays the multi-dose vials and the sub-Q administration. But still, HMG has got equal value and recommendation as the choice of gonadotropin as a recombinant FSH preparation, and you cannot differentiate between the two as far as your cumulative pregnancy rates and live birth rates are concerned. And another thing is that we don't do LH-FSH ratios. Dr. Chandana, LH-FSH ratios are not recommended to be done nowadays. With your ultrasound, with your clinical history, and with your AMH, you can very well diagnose the patient as PCO. So there was a time we used to do, LH and FSH ratios, but nowadays in current guidelines, it's not recommended. Okay, next slide.
So panel agrees that there's no role of expectant management and one has to do IUI with ovarian induction and not just plain IUI. So any protocol, we say there's no,
So I think we can
proceed. Yeah.
Just go fast with the slides. Yeah. Leave this.
Yeah. Which are the other factors one need to consider while treating couple with endometriosis and infertility? We already
Of course, you have to look at their AMH, their tubal patency, the male factor, and then proceed based on that to see whether they're suitable for natural conception or for ART.
So now we come to EFI, the endometrium fertility, the
endometriosis fertility index.
Endometriosis fertility index. Okay. Yes. Now we have to go fast with the slides, Manisha. Whatever we discussed.
So this all we have discussed that what does EFI stands for. We have a score from 0 to 10 and this score correlates strongly with the post-operative non-ART pregnancy rates. And nowadays it is the various studies have supported that it is very reproducible and a reliable index, and it does not have much inter to intra rater of variability. And also the recent advances, they are trying to calculate EFI from non-invasive method, and they have shown very good correlation with the final EFI calculated by laparoscopy.
So whether you use invasive methods or non-invasive methods for EFI calculation, your ultimate score does not vary much. Yeah. So this is something which we can inculcate into our practice very easily. Okay, next.
So we always talk about the safety of medical assisted reproduction. How safe is the medical assisted reproduction, and how effective it is in endometriosis?
So this also we have discussed.
Yeah, so we move ahead.
Yeah.
So we have discussed all these points. There's no recommendation for a specific protocol. Any protocol, depending on the physician preference and patient choice and patient this thing can be taken. For
anybody using antagonist in IUI cycles? No, that is also, that used to be, sometimes we used to do it about a decade back, but unnecessarily it is increasing the cost of the cycle and it is not recommended nowadays. And safety of ART. You have this random patient coming to your chamber and saying, Madam, IVF will increase my endometriosis. The hormones you're giving will increase the size of the cyst, will increase my pain. So you have to really reassure that this is a very strong recommendation by ISHRAE that ART is completely safe as the method of treatment in these patients. And you have to reassure them it will not aggravate the disease at all.
So this also we discussed. We move ahead. Yeah. These are the similar recommendation by the FOXI DCPR also. There is no role of nutritional supplement or complementary alternate therapies in the treatment of endometriosis. It's also one point. So with this, we move on to the next case.
So these Dr. Manisha, you're very right that these complementary, these alternative medicine does play a role in the setting of patients, rooting for it. Some patients say that, Madam, acupuncture will help and this will help and Chinese medicine. Again, there is no guideline which says that these modalities help. But maybe I think these modalities can help to reduce the stress level of the patient. I feel something which can divert her from the pain, whether it is, going to the gym or exercising or walking or swimming, anything. Just divert herself, maybe that reduces that stress and inflammatory mediators, how they act in the body. And my personal opinion, not a guideline at all. So next, case 2.
Yeah, that we move to the next case. She's 32 years, married since 5 years, primary infertility, undergone 2 cycles of ovulation induction with IUI. Her husband's semen analysis is normal. Both tubes are patent. Her transvaginal scan shows right ovarian cyst of about 4 by 5 centimeter with typical ground glass appearance of the contents. Her serum AMH is in the range of 2. So how to proceed with unilocular cyst, right side?
So anybody can describe the typical appearance on transvaginal ultrasound of an endometriotic cyst from a radiologic definition. Anybody who's deeply into transvaginal ultrasound and it can describe the endometrioma to me or to us.
It is mainly ground glass appearance and low flow.
Yes, very good. Ground glass appearance, correct. Very hypovascular.
Low level.
Yeah,
And
number
negative sliding sign will be present. If there is a bilateral ovarian cysts are present, it will give you a kissing sign.
Dr. Radha, sometimes endometrioma may be mobile and it might give you a positive sliding sign. It may be mobile also. You see, you put a scope, some of these endometriomas
May
are
be
little
associated
larger.
with rectovaginal nodule also.
Yeah, that is. And another thing, they are
And there is
unilocular.
probe tenderness will be present.
Yeah, they are unilocular cysts. You know, this is one of the differentiating points. They are hypovascular, thick-walled unilocular cysts. Whereas the other cysts, like you are hemorrhagic or maybe, you know, pseudomucinous and all the cysts, ectopic masses, you might see septa. But endometriotic cyst is usually a well-defined contained lesion in a single locule. If you put color flow with the help of power angio or a color Doppler, you will see very minimal vascularity around the periphery, which is a differentiating feature from other inflammatory lesions. You might find a negative sliding sign, you might find a positive sliding sign, and usually it might be associated in advanced cases with impacted cyst in the pouch of Douglas and typical kissing type of ovaries. Right.
So would you like to operate upon this woman for this endometrioma?
Yes, ma'am. She's already undergone.
Yeah.
Laparoscopic ovarian cystectomy is the treatment of choice, nothing else. And we have to be careful not to injure the hilum vessels. And so very careful while removing the cyst, not to injure the cortex, the remaining cortex. So in some studies, they are doing two-step procedure also, like incising and irrigating and giving 3 months period followed by excision of the cyst wall.
No,
And
no,
that
no,
is
Dr. Radha. Nowadays, you don't operate twice. Single surgery has to be the best surgery. We just listen to Dr. Damodar. There is no role of a two-step surgery in endometriosis. If at all you choose to operate, you should try to do the best surgery at the first or the initial setting. Anybody, what was the size
Ma'am,
of the...
prior to that, you have to counsel her about
4
the
and 5
likelihood of a
centimeters.
drop
Most
in
important.
AMH
Yes.
after surgery, sensitize her to the fact that there could be her ovarian reserve may get depleted following the surgery, in spite of it being a very good cystectomy. So after counseling them, taking their consent, considering that she's already had 2 IUIs and failed to conceive, I think the best approach would be laparoscopy followed by another 2 cycles of IUI and then maybe ART.
Okay. And if the cyst is actually, you know, just about a 4 or 5 centimeters single endometrioma, mobile endometrioma, the other ovary is all right, the patient is asymptomatic, you can even leave it behind. There is also a role of conservative treatment in that. You can just proceed with ovulation induction because this ovulation induction is actually not going to increase the size of any cyst or it is not going to cause another endometrioma. So there is a paradigm shift nowadays from surgical to conservative management as far as OMAs are concerned.
If at all one has to operate, what do you prefer, cyst drainage or cyst wall excision or electrocoagulation of the wall or ablation? What are the different
it is
methods?
cyst wall excision. Cyst wall excision.
Any role of pre-op or post-op medical therapy?
No.
No, there is no role.
Unless she's symptomatic.
Yeah, so the recommendation are that operative laparoscopy should be indicated if compared to the expected management. And if at all we have to operate, cystectomy is the preferred choice to increase the spontaneous pregnancy rate instead of the drainage and coagulation. And we have to counsel women regarding a reduction of ovarian reserve following surgery. And in the event of previous surgery, we have to give multiple thoughts before we operate upon the woman again. And we should not prescribe adjunctive hormonal therapy to improve the spontaneous pregnancy rate, either pre-op or post-op.
Yeah. And this is evidence level A.
Yeah.
I actually have a small doubt, madam. With regard to the same patient, you told us we can go towards conservative management and not do a cystectomy. So now she's already had 2 IUIs. So you're leaving her endometriotic cyst behind. So
No,
how
not,
many-
we were not discussing this patient. We were discussing a random patient
And
where
the patient.
endometrioma is there. She's asymptomatic. And, you know, of course, with
Ma'am,
2 IUIs done.
Yeah, so we take a random patient, but we've done IUIs and she still has failed to conceive. So would you suggest removal and ART or just direct ART?
No, those 2 IUIs, suppose you are not very convinced as to what sort of ovarian stimulation was done. Suppose this patient comes with 2 cycles of letrozole with an endometrioma of 4.5 to 5 centimeter, asymptomatic. You just found on TVS. You are not very convinced that adequate ovarian stimulation was given. I would still go ahead with 2 cycles of gonadotropin IUI.
Before a surgery. Okay.
Yes, yes.
Okay.
I think I can counsel that patient, you know, and not allow her AMH to fall below 2. She's already 2 or 2.2.
Yeah.
Yeah. Yes, yes. So I would always now, like after studying so much and reading so much, there was a time like 7 years back, 5 years back, endometriosis post her for laparoscopy. We all used to do that, you know, because we are, I think, I am a generation ahead of Sujayashri. Maybe we are the little middle people, not the older, but the middle people. So we used to operate very liberally. But now we are doing it with concern about ovarian reserve. Like every concern is towards preserving fertility as far as possible.
But if the same patient goes towards ART, would you suggest a surgery prior to ART, or you could still go ahead with an ART cycle without
I might go ahead with an ART cycle because IVF, the results of IVF are not determined by removal of a particular endometrioma. In fact, with correct oocyte retrieval or careful oocyte retrieval, you can bypass that endometrioma and still get your oocytes. But if it is coming in the way, or if there's any other factor involved, you would like to put a scope and deal with it.
We skip this slide, ma'am?
Yeah.
So
antibiotic prophylaxis already has been talked about both by Anu Chawla as well as Asha ma'am and Dr. Damodar. That wherever you inadvertently puncture an endometrioma during oocyte retrieval, and all of us have seen, I at least have seen that, you know, ground glass, that brownish fluid coming inside the tubes, and we know that you punctured an endometrioma. Just wait and watch, give a good shot of IV antibiotic, and then I give a good antibiotic coverage to that patient for 5 days, spanning the time of fresh embryo transfer. And, you know, she is usually okay. I've never seen a patient going into ovarian abscess. So there was one dreaded complication called ovarian abscess in the previous books. You know, we used to be morbidly, you know, scared of it. But never in clinical practice I've seen ovarian abscess resulting from an inadvertent puncture of a endometrium. Okay.
So as you were asking, ma'am, that what is the effect of endometrium on ovarian reserve? We have to be very, very aggressive with these women because just the presence of endometrium itself would be causing a reduction of the ovarian reserve.
And moreover, these women have got a faster decline in AMH.
Faster decline, yeah.
You know,
so we have to have more aggressive approach towards these.
So when you have an endometrioma, Dr. Sujayashri is very correct that you just be careful that you have to have a targeted approach to this patient. How many more IUIs, what protocol to use, and when to move to IVF, and counsel the patient continuously, whether you take her for surgery or not, that you're going to lose your follicles faster than others.
Does it affect your ART outcome? How does it affect your ART outcome, this presence of endometrioma? Any panelist?
Because the endometrioma affects the oocyte quality, it doesn't have any impact on the implantation, live birth rate, and pregnancy rate, but then because of the poor oocyte quality, it does affect the oocyte and embryo development.
The number of oocytes received and M2 oocytes received.
The M2
Number of
oocytes are
oocytes is
reduced
also
in this
less
case.
and the quality is also
Quality
poor.
is also. So the number of embryos obtained will be of lesser number and poorer quality, thereby affecting the total outcome.
There is a beautiful article in Frontiers of Gynecology, very recent article. You must all read it. I mean, they say that whatever said and done, that endometrioma may appear to be a secluded spot in the ovary, but the way it has got no capsule as such, and the way it compresses the surrounding cortical follicles, there is always an effect on the follicular fluid, on the granulosa cell, on the intrafollicular proteomics, metabolomics. So ultimately, the oocyte which comes out of those follicles is compromised. You will need more gonadotropins to form that particular follicle. The rupture might be affected, and definitely, as rightly remarked by you all, the oocyte quality is compromised.
Yeah, take this slide, ma'am, or should we
Yeah,
proceed?
please proceed.
So, which of this estimate protocol is there a difference in the
We'll
outcome?
discuss this, Manisha. Let's go ahead.
Yeah. So there's no difference in the ongoing pregnancy rate between the different protocols as the various studies have supported.
Who is still doing agonist protocol out of you all? Who is still doing agonist, or all of you are doing anti? Dr. Sujaya, Dr. Chandana?
We're all
Radha,
doing
Dr. Shalini? Yeah.
We're all doing the ANTAG, ma'am. None of us are doing
Yes, same here. I'm also doing ANTAG, so I don't know agonist protocol. Like whatever we used to do, we have forgotten now. Very few cases we are doing agonist, and a few cases where I felt that this patient I can't monitor and give ANTAG daily, and I was going abroad or something. I put her on, agonist. The dose of gonadotropin required is so high that whatever financial thing you are planning, it all goes haywire. So there are still groups of gynecs and ART specialists who are proponents of agonist protocol, but we are all, I think, an ANTAG.
Yeah, our generation is only.
Yes.
So the recommendation for surgery are that clinicians should not perform surgery for ovarian endometrioma prior to ART to improve live birth rate, as it does not show any benefit, and also it may negatively impact your ovarian reserve. And surgery for endometrioma prior to ART is to be considered only if they associate pain or to improve the accessibility of the follicles.
And this is not a recommendation. This is just a good practice point.
Yeah.
Right. Next. And now, Dr. Sujaya, they are coming out with an oral ANTAG. So we're waiting for that.
Yeah.
The oral ANTAG. The oral ANTAG.
Mentioned some Elgogol or Elagogol or something.
Yes,
She was
yes.
saying that,
Maybe by next ESHRE or ASRM, we should have some oral ANTAG, and that will make life even more simpler for us.
True, ma'am. True.
Yeah. Repeat surgery, like Dr. Radha, we were telling you, no indication for a repeat surgery when endometriosis is there. And even if you're trying to experiment with your surgery, or you are just, doing your initial laparoscopic surgeries, maybe the first 20 or the first 25 or 50, try not touching the endometriosis patient, because, she deserves to have the best laparoscopic surgeon operating her in order to improve her prospects. Yeah. Next.
With
Case.
that,
Yeah.
we move on.
So we are already 7 o'clock. We'll try to finish this case in 10 minutes, Manisha.
Okay, ma'am. So this is the last case. We have the 33-year Paravan Liban, married for 10 years, never used any contraception, presented chronic dilating pain in flanks. She's looking for pregnancy, and her cycles are regular but has severe dysmenorrhea and also deep dyspareunia. She has one child, just 10 years old. However, the baseline profile is normal. Semen is grossly normal. AMH is 1.3, and she also had a report of C1 done outside of 68.
So just out of the way question, role of assessing CA 125? Anybody?
No.
No role, ma'am.
No
but
role.
Does CA 125 increase in endometriosis?
Yes, ma'am, because of the basis is inflammation. So because of that, it tends to increase during endometriosis.
Okay, so there are no
We
guidelines.
have to measure the CA 125 now.
I think we cannot be so negative towards CA 125 here.
It
Number
has to
one, it's
measure
not a
CA
very
125.
costly test. It's not a very costly test. It will just reassure you against malignancy or something. And more than 40 value of CA 125, according to literature, is suggestive of inflammation associated with endometriosis, but we don't do it. But I'm just saying it's an investigation. Suppose a patient is carrying a report of CA 125. Let us not speak negative about anybody who has done it. Because sometimes, we tend to, "Arey, ye kyun kara liya" types, Sorry for speaking in Hindi. It might be, but, but we should be, always careful when we discuss the previous reports of the patient in front of the patient, and try to be very considerate for the previous treating gynecologist, who might be a general gynecologist, who might not be an ART person. So if she's carrying a report of CA 125, we have to say sometimes in this pathology, CA 125 might increase, but you are completely safe. It is definitely not, it doesn't appear to be malignancy or anything.
Any role of surgery in this deep endometriosis?
No role of surgery, ma'am, unless she's having severe pain or any such symptom. It's not going to affect the ART outcome.
Yeah.
Can you read the guidelines, Manisha?
Yeah, although the no compelling evidence exists that operative laparoscopy for D improves the fertility, it may represent a treatment option only in symptomatic patients who are wishing to conceive. And the decision to perform surgery should be guided by the presence or absence of the pain symptoms, patient age, other preferences, history of previous surgery, and other associated important factors, her ovarian reserve, and very important, estimated EFI. So again,
one question, madam. Have you seen any case of endometrioma, endometrial malignant, that is endometrioma turning to be malignant in your practice, madam?
No, I have not seen.
Any role of IUI in these women of deep endometriosis?
I'm actually coming to this case. It's a case of secondary infertility, so it's better we check her tubal patency. I think nothing has been done regarding the same.
Yeah. So this another question to you. In fact, I was asking this question to Manisha also yesterday when we were discussing the slides. Tell me, Sujaya Shri, this patient is stage 3, stage 4 endometriosis.
No.
No, she has. Would you test for tubal patency? How would you test for tubal patency in such a case? You want to try because she's basically, not been assessed for tubal patency at all.
She is actually a symptomatic patient. She's having dyspareunia. I mean, she is symptomatic. So in her case, instead of going for hycosi, we can always do a laparoscopy, which would serve two purposes. One is excision of the endometriotic lesions to relieve her symptoms, simultaneously do a tubal patency also to ascertain whether the tubes are patent. So you can do an operative laparoscopy in this patient.
Yeah, so you can do operative laparoscopy in these patients, and whenever you put a scope, naturally your tubal patency will be right in front of you. Okay, next slide, Manisha.
So IUI, it was seen that the various studies which they did, that when they did the IUI was 3 times or 6 times, the cumulative pregnancy rate was in the range of 42 versus 15%. But although the value of IUI in stage 3-4 is uncertain, but the use of IUI can be considered in some women after carefully selecting the patient.
So preferably not too many cycles, madam. Just maybe 2 to 3 cycles of controlled stimulation with IUI and then proceed with ART.
Yeah, so all these patients, I think the golden number is 2 to 3.
Not 6.
Because 2 to 3 makes you feel you have not done anything wrong. 2 and 3, you proceed to IVF. You feel safe. You feel happy that you have not done anything wrong. Basically, all of us, all ART practitioners want to do good to the patient, want that ultimately that pregnancy. So we want that path to be smooth for the patient, not very expensive, and have a good outcome.
And either way, the cumulative pregnancy rate for 3 and 6 is very close, ma'am. So
yes. No, 6 is not done nowadays. Earlier, we used to say 3 to 4, maybe 8 years back, because I was doing a panel, how many IUIs you'll stop, the best results, 3 to 4 IUIs. But now we started speaking 2 to 3. Unless it is unexplained, of course, now it's another topic itself, because unexplained, you might not be doing a good thing by doing IUI. You know, the fast trial and everything have told otherwise, but not more than 4 IUIs, and in these cases, not more than 2 to 3. Okay, Manisha.
This we have already discussed, ma'am, so we'll proceed further.
Yeah.
About the protocol again, the various studies have failed to demonstrate the difference in clinical pregnancy rate.
We are not
between-
doing agonists, so we can skip.
Yeah, so either of the protocol.
Yes.
And again, the same recommendations we have done. Any role of surgery prior to MAR in women with deep endometriosis?
That also Dr. Sujayashree has said.
Yeah, so only by the pain symptoms, and we don't.
Yeah.
Any medical therapy is effective as an adjunct to surgery for endometriosis? Like role of GnRH agonist, COC, progestogens prior
No
to
role
AR?
of, anything prior to surgery, ma'am. No pre-treatment prior to surgery.
No, it is not recommended. Very well answered by all the panelists. And there is no role of prolonged administration of COC, progestogens as a pre-treatment to ART to increase the live birth rate. Any role of fertility preservation in a woman with endometriosis? What are the indications, or in which women would like to offer fertility preservation?
You would preferably counsel the patient, especially if they have ovarian endometriomas and it is bilateral. It's always better to counsel the patient towards likelihood of drop in her ovarian reserve. So you can counsel,
Especially in adolescent girls.
Ma'am, but there's always a catch in this, ma'am. The catch is oocytes, you can't preserve them for too long as you compare to an embryo. So when you offer them to an adolescent, you have to counsel them about that also. Ma'am, what is your take on that, Manisha, ma'am?
Yeah, very rightly said that the recommendations are that we have to discuss the pros and cons of fertility in women with endometriosis, and true benefit of preservation is right now is not much supported by our studies available. So we have to discuss.
Ma'am, but Manisha, ma'am, wo jo kehte, I mean, they say that oocytes, it's difficult to cryopreserve them versus embryo. So
Yeah.
what would you, I mean, what would you tell the patient? I mean, how long, anything like that?
I'll take this question and I'll give you a very nice example. So oocyte cryopreservation is right now a hot topic, social egg freezing, and patients are coming basically in Bhopal also. We are not a top level city, but still patients are coming for inquiries about oocyte cryopreservation. I had one such patient. I did for 2 patients. The problem is the human egg is about 400 microns. It's a large cell. An embryo is compacted after it forms a blastocyst or it is cleavage cell embryo. It is easier to freeze. The thawing is also easy. The outcome is also good. But in cases of oocyte, my husband is an embryologist. So he will, when you thaw the oocyte, sometimes the ice crystals only rupture the oocyte. So a very VIP patient got her eggs frozen. She was in Merchant Navy and she did not want to marry. At the age of 34, she got her oocytes frozen at a very VIP center in India, in Mumbai. Now, after 4 years, when she wanted a baby as a single mother, she went to that center at the age of 38. Now I want to conceive. And please take out my frozen oocytes. They said after a day or 2 that we'll have to do your pickup again. Now, this patient was PCO. So naturally, the oocytes were available at 38. She said, why do you want to do my oocyte retrieval again? They said, no, we want, these oocytes also and those oocytes also. And a little story was cooked up. So ultimately, she went another oocyte retrieval, complete stimulation. The fresh oocytes were used for creating embryo with a donor sperm because she was a single woman. And ultimately, she came with a singleton healthy live pregnancy to Bhopal at 14 weeks, just after her NT scan. So this story I'm telling you, when one of the best centers in Mumbai can not have good outcome after thawing frozen oocytes, what do you tell about the current scenario? That's it.
So you don't advise oocyte preservation as such for
No,
social.
Dr. Radha, I am nobody to not advise. I am saying let us have techniques where you get good oocytes after thawing. You can, even vitrify in 4 cycles, you can vitrify 20 oocytes for that lady. Okay? But at the end of the day, when she comes to you after 3, 4, or 5 years and you thaw them and you do not get anything, you're not able to do ICSI, you're not able to fertilize, you're not able to give a reply to the patient, then what do you say? Yesterday, I got an inquiry. I got a patient from US and she had come to India for a week and she was asking about cryopreservation. Her friend had undergone oocyte cryopreservation in New York and subsequently conceived. I said, you please get it done in New York. She said, Madam, I want it done with you. Manika, no, you are living in New York. Your friend has conceived with a frozen oocyte. Please get it done from the same center in New York. This I'm telling for your good.
Most of the software employees, they are marrying after the age of 30 or 31 years, and they are asking the same question for oocyte preservation, madam, nowadays.
No, Dr. Radha, we should be good with the technique. That's what I'm saying. Let us not take money from the patient just for the sake of taking money. We should be able to give an outcome to the patient, And at the end of the day, any patient can undergo DNA test for paternity, maternity, everything. What reply will we give to the patient? Okay, so I mean, not every patient will be as lucky as that patient of mine who underwent a repeat pickup after 4 years. So we should be able to. So right now with oocyte cryopreservation, I am looking at centers in India who are doing good work, authentic work, who are getting results, not just simply announcing results. Announcing results in IVF is very different from actually having the results. And usually people who have the results don't announce, and people who announce the results don't have them. Okay.
That brings to the end of the panel, and we must applaud all the panelists for the wonderful answers and great take-home messages.
Yes.
Thank you
Monica,
so
ma'am,
much.
a small question, ma'am, at the end. Since we have delivered all our patients safely, let us talk about post-delivery endometriosis patients. Actually, I had one of my cousin who had I had put this question in the chat box, ma'am, actually.
I just read your question. I answered also. Yeah.
Okay, ma'am.
Just tell us.
She actually underwent 8 IVF cycles and finally she has twins, boy babies who are 5-year-old. During the process, we had to do the delinking for her, wherein we delinked her hydrosalpinx, and she has an endometrioma, right endometrioma around 5 to 6 centimeters and a left small endometrioma. Of late, she had menorrhagia. She actually stays far away from our place now in Hyderabad. Because of menorrhagia, when she had attended the gynecologist there, they suggested her to go ahead with LIVH with BSO, and some have told her to go ahead with endometrioma, just resection of the endometrioma. Actually, she doesn't have any symptoms, neither dyspareunia or dysmenorrhea.
She has menorrhagia, no?
It's just menorrhagia, ma'am. That's it.
Why don't we try Mirena? Why don't we try a Mirena?
Yeah.
Why go for something as radical as an LAVH?
Yeah, that's what, ma'am. So actually what I did to her was I did an endometrial biopsy with HPV DNA testing, which have come out to be negative. And actually what happened is the subsequent cycles are normal for her. So as of now, I just started reassuring her that nothing would happen. But the question to the jury is she's scared of endometrial cancer in her endometrioma, and anything else can happen to her after 8 cycles.
You have to reassure her there is very minimal chance of conversion of endometrioma into malignancy.
Okay.
Almost equal to the normal population.
Okay.
Her only symptom is menorrhagia, which can be controlled by hormonal suppression or by LNG-IUS.
Actually, her subsequent cycles are normal, ma'am, now. Only those 3 cycles, she got panicked and she consulted actually an oncosurgeon there.
Dr. Chandana, you just have to reassure. If your counseling is good, she might be, not undergoing hysterectomy unnecessarily, but all said and done, in India, even if you say no hysterectomy to any patient, the 3rd, 4th, 5th, 7th gynecologist will take out the uterus. So, and the patient will be very happy, Madam, hysterectomy kara liya, and all that time you have been racking your brains and counseling that patient, because she's your relative and you're concerned about her.
Yes, ma'am.
So this hysterectomy and the way it is done in India is a totally different ball game. So that is a very controversial
Madam,
topic. But
can I ask one question, madam? I am having one patient. She is having adenomyosis, and the size of the uterus is around 9 to 10 centimeters, madam. And small cysts are present throughout the myometrium. Except for that, she is not having any symptoms like dysmenorrhea, dyspareunia, and now and then menorrhagic cycles. She had one preterm delivery, and now she is having that baby died, and she presented to me with the secondary infertility, and have given ovulation induction with IUI three times, madam. Not yet conceived.
what
Till
is
now.
what is her classification according to Sunita Madam's classification? You listen to Sunita Madam's lecture. What is her classification according to Sunita's classification?
Oh, madam, the both and I have heard, madam, the size of the uterus is less than 10 centimeters, and
It is diffuse adenomyosis.
No, madam, less than 10 centimeters. Small endometriosis is throughout myometrium.
This patient who has got a generalized enlargement of the uterus, the whole uterus is diffusely enlarged. Is diffuse?
Not diffusely enlarged, madam. Only 8 to 10 centimeters, 10 centimeters size. 8 to 10
But it
centimeters.
is uniformly enlarged.
Yeah,
no?
yeah,
It is an adenoma. It's a uniform.
Yeah, adenomyosis.
These patients, what we have observed is they do poorly with implantation.
Okay.
Even if you do repeated IUI ART cycles, she might have poor implantation. And these patients, if the uterus grows to 12 centimeter, 15 centimeter gradually, they might have, they might have to go for something like surrogacy or something. But still, I mean,
She had one preterm delivery, madam. She had one preterm.
So the only option is probably, to counsel her and keep trying with 2 or 3 cycles of gonadotropin IUI. If there is no implantation, negative test, or you can go for IVF. And if IVF also fails, then just leave it. Some of these patients, they just conceive spontaneously down the line.
Thank you.
But the talk taken by Dr. Sunita Tendulwadkar madam was totally according to what case you are telling us.
Yes, I had.
She has put your sort of patient with diffuse adenomyosis as Dr.
Grade
Sunita's classification stage 3-4.
Yeah, 3, stage 3.
3 with very poor prognosis. But still, we have seen adenomyosis patients conceive.
So why incidence of adenomyosis nowadays increasing so much? We are seeing so many cases of adenomyosis up to even 16-20 weeks size also associated with fibroids, madam.
I don't know about incidence, but diagnosis is definitely increasing because all of us are doing transvaginal sonography. All of us are, basically putting the
size of adenomyosis is up to 16 weeks with associated fibroids. The married coming within 1 year of marriage, they are coming for infertility treatment, and we are diagnosing many cases of adenomyosis associated with fibroids and infertility.
Nowadays, they are even saying a genetic predisposition. Usually, if the mother has fibroids and adenomyosis, the daughter will also have fibroids, adenomyosis. Sometimes with adenomyosis, fibroids, there is endometriosis also.
Yeah.
That is a triple sort of whammy you're getting. You're getting all sorts of these disorders, and this is just the outcome of delayed marriages, I feel. Most of the girls nowadays are not choosing to conceive before 30. They are not choosing to settle down or have a partner before they are 32, 35. Then also they are thinking about oocyte cryopreservation. So the early marriage thing, when our mothers had us when they were 23, 24, 25. Okay. So when we were 15-year-old, our generation, our mothers were 40, 42. But nowadays, even till the age of 35, they don't think about the first child. They think about marriage after 35. Then they think about a baby at the age of 38 and they land up with the ART people. So this is the reason, that all that estrogen dominance in the body, the progesterone resistance, it gives rise to all these pathologies.
Okay, madam. Thank you, madam.
You still see a woman coming from rural area who's 22, 23, 24. She'll have a perfect, beautiful uterus, beautiful endometrium, beautiful ovaries. You'll say, oh my God, let me take a picture, screenshot. Such uteruses are so rare nowadays.
Yes.
So
Thank you, madam.
Yeah, thank you
Thank
so
you
much.
very
It
much,
was
sir.
so, it was
We
so
want to be in
lovely.
contact with you, Madam Monica, madam. It is a very nice lecture and very nice discussion. I want to be in touch with you in future also.
Thank
Because
you. Thank
we
you
are
so
having so
much.
many patients
No.
with adenomyosis and endometriosis and infertility.
You can save my number, Dr. Radha, and we never dissolve these groups. All the perfection
Okay.
groups are as it is. If you don't exit the group, I'm always in the group. We can always keep in touch with each other. And thank you so much for all of you for being there, giving tremendous inputs. Thank you to my dear, sweet Manisha and Purnima. They are my left and right arms. They have put together. All the slides were prepared by Dr. Manisha. And my younger brother, Dr. Vishal Dave, for giving us excellent
Thank you, madam.
opportunity. And just now I met Vishal in Ahmedabad also. And because of him, we have lost the World Cup. So Gujarat people did not do anything for India. Okay, so thank
Madam,
you.
you are coming to AICOG, madam.
Yes, I'm coming to AICOG. Yes.
Okay, we'll meet there, madam.
Okay, now a humble request. I'm going for chairperson Foxy Perinatology Committee election
know, but
2024.
all the best for your elections, madam.
My passion is fetal medicine.
Support, yeah.
Thank you so much. Thank you so much.
All the best, madam.
I'll be so grateful if you could
No,
give me
it would be an honor, ma'am. It would be our pleasure, and we'll sensitize the neighboring societies also.
Thank you so much. Thank you, Intaz. Thank you, everyone. Have a
Thank
great
you.
day and have a great evening. Bye-bye. Bye.
Thank you.
Bye. Bye.